Thank you. Good afternoon to all of you. I, Dr. P.S. Roy, being the Assistant General Secretary of the Association of Northeast India, takes the privilege to welcome you all on this 17th Annual Conference of Association of Northeast India. As you all know that this time, the 17th annual meeting, we are planning to do this physical platform at Agartala. But somehow, because of some logistic issue, we had to shift it to either Guwahati or to Shillong. But then, because of the prevailing COVID situation, we are not doing this thing in the physical platform. So we are meeting here today on virtual platform. I'm extremely sorry for this thing, but this is beyond our control. Hope we can meet next time physically. As you all are aware that we are sitting in the hub of cancer capital, because northeastern states are known as cancer capital of India, with very high incidences of few cancers to name, which like gallbladder cancer, oral cavity cancer, nasopharyngeal cancer, hypopharyngeal cancer, esophageal cancers, amongst others. And it is our most earnest duty to keep ourselves updated, keep ourselves informed about the newer information which is going over worldwide, keeping our local informations, local limitations in mind. So I feel this type of platform, this type of meeting, which is confined to the oncological setup, will help us enriching our knowledge, enriching our own experience by sharing our own ideas, our experiences amongst others. This is not only help ourselves, but in addition, I feel our students, majority of us, we are attached to some of the medical colleges somehow. So our postgraduate students are also going to be benefited immensely from this 2-day scientific forum. And over the next span of 2 days, probably we are seeing too many speakers, both from local region, also from rest of the part of the country, who will enlighten us about the different topics on oncology. And at the same time, we have also kept a few real case-based scenario, which will actually give us impetus on the how we are dealing with those cases on day-to-day basis. So with this much, I once again welcome you again on this 17th AONEI meeting, for which will be a 2-day CME. And I will request everyone to kindly involve yourself and also involve your colleagues and your juniors, so that this meeting become a grand success and the meeting will end up with a fruitful result. With this much, I would like to now take the opportunity to invite our present president of the association, who is none other Professor Dr. C. Bhuyan. Dr. Bhuyan does not need any introduction to this august gathering. However, for the sake of introduction, I will just give a brief introduction of him. After pursuing his degree in medicine, he has started his oncology career at Dr. B. Purohit Cancer Institute. And after a long 19 years service at Dr. B. Purohit Cancer Institute, he has retired as a professor and head of the Department of Medical Oncology. And presently, he is working as a consultant medical oncologist at Nightingale Hospital and Apollo Hospital. With these few words, I would like to request Dr. Bhuyan sir to kindly say a few words and inaugurate the meeting formally. Bhuyan sir, over to you, sir.
Okay, my voice comes to you. Hello?
Yes, sir. Audible, sir.
Yes, we are audible.
Yeah. Very good evening to all the members who are online in this forum today for the 17th annual conference of our beloved association. Martha has already told the situation under which we had to finally call for a meeting on the Zoom platform. I really feel sorry for Dr. Arup Roy Burman, who tried all his best to hold this meeting in physical form at Agartala. But finally, we saw that the difficulties that is upcoming because of the COVID surge, uncertainties started coming up. And finally, today we are here today. So we are all together with Dr. Arup Roy Burman's team at Agartala. It's not that we have neglected that place. Arup, please don't take it that way. Join and enjoy this meeting. I appeal to the Agartala team. I'm very happy here to say that many of our members have taken the trouble of spreading cancer awareness and CMEs done at different places. I especially mentioned Gayatri Gogoi here. She has an organization with her which is named Pratisruti. It's a organization for palliative care at Dibrugarh. She had collaborated her Pratisruti with AONEI, and she has organized cancer awareness meetings at Tinsukia district, Dibrugarh district, Jorhat district, and even in Morigaon district. So it's a great effort. Dr. Rubu Sunku has organized the CME on thyroid cancer under notice of 1 month period. Great effort from the team Arunachal Pradesh. I wish these two were the successful programs AONEI could do in the trouble-torn year last year. And organizing this annual meeting today. Please join this meeting. I appeal to all the members. We have tried to get resource persons, although these were all done very hurriedly. Now we are here. Let us participate, enjoy, give our inputs for the further growth of the organization. When time comes, you put in your own effort and enjoy. I welcome you all to this 17th annual conference. And I hand over the mic to Partho once again. Partho.
Thank you, sir. Thank you for your nice words. And now I take the opportunity to invite our honorary General Secretary of the Association, who is none other than Dr. Vikas Jagtap. As you all know that Dr. Vikas Jagtap is a highly dynamic and very young, energetic person who is a very good friend of mine. And presently he is attached to North Negrims, Shillong, and working as Associate Professor and in charge of the Department of the Radiation Oncology. And he is going to give us some brief introduction about this meeting. So Dr. Vikas, over to you.
Thank you, Partho, and thanks for the introduction. So I welcome, on behalf of AONEI, I welcome all of the members, delegates, and the speakers for this 17th annual conference. We tried to hold it in a physical format, but because of the new pandemic wave, we were forced to shift on online platform. So here we are today. Yesterday we had a good session with around 21 posters which were presented from all over Northeast and even from other parts of India also. We had good session yesterday with all the speakers and the judges who appreciated the posters. We had 2 days scientific program starting from today. Today we'll be having esophageal cancer, breast cancer, sponsored talk on ovarian cancer, and 1 panel discussion on rectal cancer. I thanks to all my seniors, especially Dr. Bhuyan sir, who is our president, Dr. A.K. Kalita, who is the advisor of the association, and all the Northeastern State Zonal Chapter executive members who are there. Also thanks our senior members from Northeast, Dr. B.C. Goswami sir, who is already there, Dr. Kudush Ahmed sir, who has supported always, and thanks to all of them for making this conference successful. And once again, I invite all of you and we expect to have a healthy and good academic discussion over the next 2 days. And I welcome you all for the program. Over to you, Partho.
Thank you, Vikas. Thank you for your nice words. Now I take the opportunity to invite our present advisor of the association, who is Professor Dr. A.K. Kalita. Dr. A.K. Kalita sir is currently working as professor and head of the Department of Radiation Oncology at Dr. B. Bora Cancer Institute, Guwahati. Sir Kalita sir, over to you, sir.
Yeah, good evening, everybody. And yeah, this time we have formed it virtually. Hopefully in the next year, we'll make it physically. And I thank Dr. Vikas Jagtap for taking the initiative to make it from the Nagrims, and his team effort is really, really marvelous. And I wish all the success for this conference. And I thank especially Dr. Bhuyan, the president of AONEI. He has taken a very keen interest, and he was the founder of this association to take to this mile, and he is still there today. So I thank him also. I welcome everybody. Thank you. You enjoy the conference. Thank you. Over to you, Pater.
Thank you, sir. Thank you for your nice words. So this comes towards the end of this inauguration ceremony. This much is from my side. And once again, I would like to welcome you all one more, and thank you once again for your patience hearing. So enjoy the academic fiesta. And again, I request everyone to involve as much as possible your juniors, your colleagues, whatever may be, to make it successful. Now I would like to hand over the session to Dr. Anisha, who is going to coordinate the next session with the first scientific session. Over to Dr. Anisha. Dr. Vikas.
Hello.
Hello, Dr. Anisha.
Yeah, sorry.
Good.
So, yeah.
Okay.
So
Okay.
we'll be starting the session, and Dr. Antya Lisha Nonkingri, who is our senior resident in radiation oncology in our department, she'll be the session coordinator. So I hand over the session to Dr. Antya. Yes, Dr. Antya, please go ahead.
Okay. Good evening, everyone. I take the opportunity to wish each of you a happy new year. And I welcome each of you to this conference. So we'll start over with our first session of the evening on esophageal cancer. I would like to invite our chairpersons, Dr. B.C. Goswami, Director, State Cancer Institute, GMC Guwahati, Dr. A.K. Kalita, Professor and Head Department of Radiation Oncology at BPCI Guwahati, and Dr. Juditas Aimde, Radiation Oncologist from Shillong, who's also the founding member of the AONEI, to take over and start the session. Thank you.
So I think we can go ahead with this session. Apurva?
Yes, sir.
Okay, our first speaker is Dr. Abhijit Talukdar, who is the professor in surgical oncology at Dr. B. Burra Cancer Institute. And he is going to talk on surgical approach in carcinoma esophagus. Dr. Abhijit, please.
Am I audible, sir?
Yes, yes,
Yes.
audible.
Yeah. Good afternoon, chairpersons. I will start my screen share. Is my screen visible?
Yes. Yes, Abhijit, you can go ahead.
Oh, thank you, sir. So any surgical approach in esophageal cancer, I will be highlighting the different modalities, the preoperative evaluation, the neoadjuvant treatment, and the surgicals. Yes.
Abhijit, can you make it full screen? It's not in the presentation mode
It's
yet.
full screen actually. Okay, just let me check.
No, it's not yet full screen.
Just give me a minute.
Yeah. You make it a slide presentation, no? It's still coming as a pic. Yeah. No.
Full screen one.
No, you have to start the slideshow. The
Okay. So it's like
icon on the slideshow.
okay, just a minute. In my laptop, it is showing as full screen. Okay, let me check once. Is it not full screen because?
No.
It's showing the PPT only, not as a slideshow.
Okay. Just give me a minute.
I think I'm seeing the same thing as others are seeing.
Hello.
Okay.
Actually, Dr. Abhijit, you can just stop share.
Dr.
Okay.
Abhijit, you had shared the thing. I think Ravindra, you share from your side.
So you, Dr. Abhijit, you can just stop your share.
Just a minute. Just yeah.
So now you can put your presentation on presenter mode, then click on the share button, then directly select the presenter mode.
Is it full screen now?
No, so we can't see it on full screen. So should
You
I
go to
share
the
from my side
right
here?
side column, na, there is a symbol of a cup. You click on that cup where we can increase the right.
I have used that only in the slideshow. I don't know why it is not showing.
Here it is not coming.
So just click on it.
Just click on it.
Yeah, I've clicked there only. It is showing
actually, Dr. Vikas, he is clicking on that slideshow, but it's not showing to us. So can I share from here your presentation? Just suggest me for the next slide.
Okay.
Can we share from this side?
Then again, okay. I actually, because time was less, slides were more. I thought that. Yeah, probably. Sorry for the technical. Is it full screen now?
No, sir.
I think, Abhijit, I think it should be okay.
Anyway,
It's okay, sir?
Yeah, we can go ahead.
So can you move the slide? So can you move the slide? One or two slides?
It's moving. It's moving.
Yeah, but our side it is
we
not
can't see.
Oh,
We can't
it's not
see.
I think Ravindra, share from your side better. There is some error coming up.
Yes, sir, sure.
Yeah, now it's okay.
Okay. So today, sorry for the technical problem.
So no
Okay,
issues. Just
sir.
instruct me for the next slide when you want.
Yeah. Okay. So today, basically, I will be discussing on the surgical approach in esophageal cancer. Can I have the next slide? Next slide. Yeah. Any surgical strategy should be balanced between the decision of a RGO resection, giving a potential cure, or an incomplete resection, which leads to R+ resection, which has a dismissal progress. So, next slide. So always our aim should be, in respect of the histology, it should be R0 resection. R+ resections or bypass procedures have been abandoned. So these results can be achieved in high volume centers. Next slide. So we have to consider in the patient factors where severe morbidity, we have a clear-cut decision of not going for esophagectomy, whereas in case of marginal fitness, we have to do preoperative optimization or enhanced recovery post-surgery. Next. Yeah, it is personalized multimodal rehabilitation, that is improved physical activity, respiratory training, respiratory exercise, nutritional and psychological well-being, removing bad factors like smoking, taking control of comorbid factors, and have an enhanced recovery post-esophagectomy. Next. Basically, clinically it is classified as an early esophageal cancer, locally advanced, and metastatic cancer. So today, basically, our discussion would be on locally advanced cancer, though I have put a slide on early esophageal cancer, which comprises a very small proportion of the esophageal cancers that we see. Is mainly defined by in situ tumor or a limited mucosal invasion. So criteria for treatment is that lesion should be less than 2 centimeters, a well-differentiated carcinoma, and with no evidence of lymph node spread. The management strategies for this type of early esophageal lesion is a minimal invasive endoscopic resection, which can be either a submucosal resection or a submucosal dissections. Coming to the next. A locally advanced cancer, which is mainly defined as a disease which is more into the submucosa and the musculus propria with or without involvement of nodal involvement. So the strategies as enlisted earlier is a preoperative optimization, then a multimodal approach with radiation, chemo, and surgery being combined together, which was given as evidence for the cross trial. So the mode of trimodality approach is the standard of care for any locally advanced esophageal cancer, because it has shown a survival advantage of 49 months and RGO resection rate of 92%. Next. So the extent of esophagectomy is dictated by the anatomical peculiarities of esophagus because of embryogenesis, arising from the mesoderm and the branchial arches, with the tracheal bifurcation acting as a watershed line between any tumors above this line mainly drains into the upper mediastinal and cervical nodes, whereas the lower esophagus drains mainly into the perigastric nodes. Any tumors in the subcarinal region has the propensity to drain either above, that is in the upper mediastinal, or the lower mediastinal nodes. This also is described by the histology, mainly the primary squamous cell will have a more lymph node spread, whereas the adenocarcinoma will have a limited spread. Next. So criteria for resection are that if it is a very early lesion, that is a T1B or T2 with no nodal involvement, esophagectomy forms the first line treatment therapy, whereas any lesion that is beyond the mucosa or with a T4 involvement, that is the limited pericardiac or a diaphragmatic involvement, or with nodal involvement, neoadjuvant treatment should form important strategy for this kind of esophagectomy. In case this is mainly driven by the histology type, whereas in squamous cell we use a combination of neoadjuvant chemo-RT, whereas in adenocarcinoma we prefer more of neoadjuvant chemotherapy. Next slide. Next, yeah. So any evaluation should be evaluated properly with know that it is an endoscopic biopsy, which gives a clear-cut diagnosis in 98% of patients. And this should be sufficiently evaluated with the help of CT, neck, thorax, and abdomen. Though PET-CT has helped us in detecting occult diseases, where it upstages the disease from different diseases from 15 to 30%. Any esophageal cancer with involvement near the tracheobronchial tree has to be evaluated with the help of bronchoscopy. The diagnostic laparoscopy for peritoneal diseases forms an important component of a G-junctional adenocarcinoma type 2. Next slide. So the surgical approach is defined by what is traditionally known as the open approach, which different components are the transhiatal esophagectomy or a transthoracic or a Ivor-Lewis esophagectomy. And another approach is a minimal invasive esophagectomy or a robotic minimal invasive esophagectomy. Or we can have a combination of either a open approach or a laparoscopic approach forming the hybrid approach. Next. Before the advent of neoadjuvant treatment, there were a lot of discussion whether which approach is better, a transhiatal versus transthoracic esophagectomy. But these randomized trials, next, from the Hulser, here shown that the transthoracic esophagectomy gives a 14% survival advantage, though it was not statistically significant. But on subgroup analysis, it was found that in lymph node positive patients, undergoing thoracic esophagectomy has a 5-year survival of 20% and a disease-free survival of 41%. Next. With the advent of neoadjuvant treatment, chemotherapy, there was another change in the concept of mesoesophagus, which was proposed by Miguel Cuesta, who said that the esophagus is covered by a bilayer membranous layer from the aorta and engulfing the esophagus and its lymph node packet into an anterior compartment comprising the esophagus, the subcarinal nodes, and the vagus nerve, and a posterior component composing the azygous vein and the lymphatic trunk. These form the important component of a partial mesoesophageal resections. This was again highlighted by the Japanese, who proposed the supracarinal anatomy with the demarcation of the left recurrent and the right recurrent, and removing of the left recurrent and right recurrent laryngeal pocket, with combination of both these subcarinal and the supracarinal forms the total mesoesophageal resection. Next. Next. So what are the evidences of the open versus a minimal invasive surgery? This was a Dutch study which showed that it has a better short-term post-operative functional recovery compared to open thoracic approach. Next. So again, the time trial was mainly to say that the minimal invasive can be safely applied in case of neoadjuvant treatment, because there were a lot of apprehension regarding post-operative radiation fibrosis, the planes not being proper, and it also demonstrated that pulmonary complications were reduced and there was a improved quality of life without compromising the long-term survival. Next. So there was again discussion between the robotic versus the wedge. With the advent of the robotic esophagectomy, there was a comparison, but this indication that the robotic approach has a similar feasibility and safety in esophagectomy. Next. So these trials, next slide. Yeah, these trials, that is the RAMI trial and the Robot 2 trial, they showed that it has both being safe and feasible for the treatment of esophageal cancer because it has a shorter operative duration as well as a better lymph node yield, but long-term results are still to be matured. Next. So if you see the different conduits, the stomach is the most common conduit to be used, but in case of non-availability of stomach, we can either use the colon and the jejunum. Next. So this stomach tube formation, it has to be seen that it has to be well vascularized graft, preservation of the gastroepiploic arcade, preservation of right gastric artery. Then there should be proper staple alignment, and the staple line should be parallel to a lesser curve, maintaining at least the conduit diameter of 3 to 4 centimeter. Next. Because of the advancement in technology, now we have the indocyanine green, which not only gives us a physical delineation of the stomach tube, the vascularity, we have now a visual impact of the indocyanine green, which helps us to delineate the vascularity of the stomach tube. Next. So the main surgery, the patient comes with dysphagia, patient should not go with dysphagia. So anastomotic techniques is very important, but before that, we have to have a two vascularized tissue, that is the stomach tube and esophageal remnant. The traditional hand-swing anastomosis may have a role in case of a high esophageal lesion where margin is a question, but we are experienced. Next slide. We have experience with staple technique with hand-swing versus the staple anastomosis, which has shown that the stricture rates in staple anastomosis were as low as 7%, whereas in hand-swing it was more than 17%. So this has shown that the staple anastomosis has shown that it has decreased the stricture rate, though the leak rates may not decrease to that extent. Next. Next. Yeah, these are the operative photographs. You can well see that these staple line, we have a wide staple anastomosis, so the patient has a better compliance of the nutrition. Next. Next, yeah, you can just follow. Can we next slide? So these are the intraoperative photographs. Value of the lymphadenectomy post-neoadjuvant treatment. This initially the cross study, there were data of analysis by Salma, who showed that in case of a post-neoadjuvant treatment, the number of resected was not associated with survival. But other studies have showed that increased lymph node yield from esophagectomy is associated with improved survival. So further studies are warranted to assess the survival benefits of a higher lymph node yield post-neoadjuvant therapy. Next. So there was a lot of, because of the varied Western and the Eastern, there were a lot of confusion regarding the lymphadenectomy. So the International Society for Disease of the Esophagus in 2003 came with the standard definitions of a standard two-field dissection, which involves a modified D2 dissection on the stomach and the removal of the station 9, 10, and the station 7, which forms the standard two-field dissection, whereas extended two-field dissection is the removal of the right laryngeal lymphatic packet, whereas three-field dissection is the clearance of the lower cervical and the supraclavicular nodes, as shown in these three diagrams. Next. So there is a variation of this lymph node metastasis in squamous cell carcinoma versus adenocarcinoma. If you see in the left-hand side, the main lymph node burden is in the mediastinum, both in the upper mediastinum and the mid mediastinum. And there is a 10% chance, 11% chance of a cervical lymph node metastasis. Whereas if you see on the right-hand side, that in adenocarcinoma, there is a very less chance of a 10% chance of a supracranial or a subcarinal node metastasis. So this forms the philosophy of doing a lymphadenectomy in both squamous cell and adenocarcinoma. Next slide. So these are the intraoperative photographs. As you can see, these are labeled. So this is a two-field clearance where you can see that subcarinal nodes, the visualization of the left main bronchus, the right main bronchus, the pericardium, and the delineation of the right bronchial artery and the azygous vein. Next. Yeah, this is the supracranial dissection where we can see the trachea and the azygous vein, the left recurrent laryngeal nerve on the right hand side is the devolution of the subclavian artery and the right recurrent laryngeal lymphatic pocket. This is a three-field lymph node dissection. Next. Next. Yeah. So what are the evidences? Can you go to the previous slide? Previous slide. Yeah. So this is the the recent RCT from the Chinese. They have a high, this had a high propensity of squamous cell carcinoma. So in case of middle and lower thoracic esophageal cancer, they have found that there was no improvement in survival, overall survival and disease-free survival in the three-field lymph node dissection over two-field lymph node dissection. Next. So a bit about G-junction tumors, because adenocarcinoma of the distal esophagus, which is from the anatomical cardia, from 1 centimeter to 5 centimeter, forms a type A, type 1 tumors, whereas the true carcinoma of the cardia, that is the 1 centimeter to 2 centimeter of the stomach, this forms the type 2, and beyond that forms the subcardiac gastric carcinoma. The subcardiac gastric carcinomas are treated like a stomach cancer, whereas adenocarcinoma of the distal esophagus is treated like a esophageal cancer. Next. So if we see that in the type 1 type of adenocarcinoma, we see that the lymph node metastatic pattern is different from squamous cell. You have less of the subcarinal node and the cervical nodes. So what is the treatment strategy that we apply here? Next. So we do a subtotal esophageal gastrectomy with a two-field lymph node dissection. This is based on the concept that the submucosal spread to the proximal esophagus, even in the infiltrative type or the mucinous type, outside the area of metaplasia is relatively rare. So there is no philosophy in doing a subtotal esophagectomy. This is not a must in patients with distal esophageal adenocarcinoma. Next. There can be other approaches, the transmedicinal approach or a left thoracoabdominal approach, also known as the sweet approach. This is thoracic approach is more for these younger patients who has got more lymph node burden as diagnosed by a CT or a PET scan, and mainly for young and healthy. Whereas a transmedicinal approach is for the weak patients or patients who are in the borderline range. So where we can see that there's a reduction of operative risk by sparing the thoracotomy. Next. So in type 2 adenocarcinomas, we can either do a subtotal esophagectomy with subtotal gastrectomy and a two-field lymph node clearance. Next. Again, the AGCC in the 8th edition, they have come with the concept of the epicenter of the cancer, where they say that any cancer, epicenter of cancer which is less than or 2 centimeter into the cardia is treated like an esophageal cancer, and epicenter of cancer which is more than 2 centimeter cardia as a stomach cancer. This is another view of how to treat the lower esophageal and the G-junction cancers. Next. So how we avoid complication of surgery? This is precise dissection so that important nearby organs are carefully exposed. The main thing is the lymph node dissection, the injury to the recurrent laryngeal nerve. These nerves should be dissected at the branching point of the vagus nerve and around the aortic arch. Avoid extensive dissection of the epineurium. Avoid using direct pottery or the harmonic scalpels or any energy source, and cold weapons like scissors or blunt dissections can be used. Then another component is the membranous trachea or the main bronchus injury. Because of extensive lymph node dissection, the harmonic or the working blade can cause immediate injury or delayed injuries. Delayed injuries can manifest as a fistula. So there must be intermittent cooling to avoid overheating. Another problem that treatment phase is a chylothorax. So it is recommended that thoracic duct should be clearly exposed during the mediastinal lymph node dissection and should be examined upon completion of dissection. And if any injury is suspected, this duct should be ligated near the hiatus. The pulmonary postoperative complications are one of the functional morbidity and a leading cause of mortality. So preserving the bronchial arteries and the pulmonary branches of the vagus nerve forms an important component of esophagectomy. Next. To conclude, advances in surgical device with energy sources, better instrumentation, and in advancement in imaging techniques have contributed to a transition from an open esophagectomy to a minimal invasive esophagectomy. This has helped us reduce the post-operative pulmonary complications and improve the short-term quality of life. So anatomy-based resection, that is mesoesophageal resection, has resulted in better negative CRM, resulting in better locoregional control. Next. Lymphadenectomy, adequate lymphadenectomy and lymph node staging does comprise both quality and quantity aspects and has removal of sufficient number of nodes at the anatomical correct position. Thank you.
Thank you, Avijit, for
Thank you.
covering the surgical aspect of carcinoma esophagus so beautifully within a very short time of 15 minutes. And we'll take up all the questions for the 3 lectures. So I request my co-chairpersons to take forward for the next lecture.
Thank you.
Apurva or Judita, are you there?
Yeah. So the next speaker is the chemotherapy in esophageal cancer. And the speaker is Dr. Duncan Kanikar, BBCI Guwahati. Okay, I think Dr. Duncan.
Good evening to all.
Yeah.
Am I audible, sir?
Yeah, audible.
Okay, good evening to all. I'll begin my screen sharing. Is my slide visible?
Not the full screen. The same problem I think arises. Jagtap?
Yes, sir.
Is it visible?
Yeah, it's
So the
visible.
slides are visible.
Okay.
Slides.
So please put it on presenter mode.
Yeah, I already have actually.
I think you can go ahead with this.
Yeah.
But
Uh,
just click on the next slide.
Is it okay?
No, it's not moving. That's what.
It's showing that it's your screen sharing.
Yeah, but
So can you please reshare your presentation?
Okay, I'll try again, sir.
Now is it visible? Is it visible?
yeah, it's visible, but not in a full screen.
Is it visible now?
It's visible, but not in a full screen.
I think it's in full screen. Is it visible? Next page.
No, I think there is issue from your computer where same issue is happening.
Now is it visible?
It's visible.
Now it's in full screen.
No.
Is it?
No, sir, not yet.
No,
So can
not
you
yet.
click, without going to full screen, can you click on the second slide, third slide, fourth slide?
Okay.
Yeah.
No.
No, it's not
moving. Now?
Yeah,
Now it's moving. sir.
Yes.
Yeah.
Okay.
Yeah. you can continue. Yeah.
Can you see my second slide?
No, sir. So don't go full screen
Okay.
because going full screen is having problem.
Okay.
Just
Yeah.
click on the
Okay.
press
Continue with
key,
the
down key
normal
button.
process. Yeah.
Okay. Okay. Then I can start.
Yes.
Good evening to all. Good evening to Bhuyan sir. Good evening to Goswami sir. And good evening to all my seniors and my colleagues as well as students who are present online. I thank AONEI for giving me this opportunity to become a speaker for today's webinar. My topic is chemotherapy in esophageal cancer. So it's actually a very big topic considering the importance of esophageal cancer, especially in this part of India. But I would like to state two facts before starting. There are certain controversies associated with treatment of esophageal cancer. I'll just touch upon the points, but I will not go into the controversies. So I will try to show the greener features of the treatment of esophageal cancer and give a view from a medical oncology point of view. So just in short, to brush up our basic epidemiology and anatomy, esophageal cancer accounts for almost 6% of all malignancies. Globocan 2020 India has stated that it is the 5th most cancer in India, but also the 5th most deadliest cancer here. Anatomy wise, it is cancer, esophagus lies in between the head and neck proper as well as the stomach. So it carries characteristics of both head and neck as well as stomach. There are two, the histology wise, in the normal histology, we'll find that the esophagus has mucosa, submucosa, muscularis, and as well as appendicia without the serosal layer. So what are the histologies of esophageal malignancies we commonly find? We find squamous cell carcinoma, almost 40% of esophageal cancers. Second comes adenocarcinoma, followed by other few rarer histologies. And it has been observed for the last 3 decades that the frequency of adenocarcinoma esophagus is, especially of the esophageal gastric junction, has been increasing, especially in the developed countries. So whenever we talk about esophageal cancer, we are concerned about 2 major histologies: squamous cell carcinoma, adenocarcinoma. It seems like esophageal cancer per se competes with 2 histologies together to confront the superiority. Now let us go through certain characteristics of esophageal cancer, and this should always be kept in mind before we go for management of any esophageal cancer patient. So there are 2 major histologies, as you've already discussed: squamous cell carcinoma and adenocarcinoma. Responsiveness vary quite a lot in between the 2 histologies. Squamous cell carcinomas are RT responsive. Adenocarcinomas are considered more chemo responsive. They have a high loco-regional failure, and what was earlier thought that they do not disseminate early, but probably that is not so. We have understood that they have early distant dissemination. 50% are metastatic at presentation, and unfortunately, the 5-year OS has still remained very low in spite of the best local therapy. So here comes the need of systemic therapy, and this is necessary because we have to address the early spread of esophagus through systemic treatment. So concurrent chemotherapy and radiotherapy is now considered a standard non-surgical management of locally advanced esophageal cancer, and preoperative chemo or preoperative chemoradiation are also considered standards of treatment. So ultimately we find that systemic therapy will ultimately be used in esophageal cancer at any point of time. So what was considered a very locally aggressive therapy has now, we have all turned towards systemic therapy for management of esophageal cancer. So for a medical oncologist, what are the tools that we have to tackle this problem? Definitely from historical point of view, they started with single agents. So single agents, a lot of single agents were tried, starting from bleomycin to cisplatin, mitomycin, irinotecan, but response rate came out to be just 20% for both squamous cell or adenocarcinoma. It couldn't go beyond 20%. So if we consider response rate to be the marker of response of chemotherapy, then this should be considered a very moderate response. So obviously medical oncologists were not satisfied, so they tried combinations. first double combinations, dual agent combinations, and then they tried triple agent combinations. Triple agents or dual agents, they found that cisplatin 5-FU combination provided the best benefit, and now the response rate has increased to 35 to almost 50%. But mostly now it has been found that adenocarcinoma responds better than squamous cell carcinoma. In recent times, there has been the advent of FLOT, and FLOT has found, we have found that response rate has increased to more than 60%. Only in adenocarcinoma, I should state, and this has been a success story for medical oncologists. Toxicity definitely is significant, especially triple drugs, but I should say tolerable. Some non-cisplatin based regimens have been tried and response rates have been comparable, but definitely not up to the mark. So in terms of efficacy, if we consider efficacy to be equivalent to disease-free survival or if we are comparable to overall survival, then triple agents will always win the race. Maybe double agents come close together, but definitely single agents fall way behind. So whenever we want to give the best efficacious treatment to an esophageal cancer patient in any setting, definitely we should try triple agents, or if not triple agent, at least double agent. But now the concept of chemo with targeted therapy, by targeted therapy also include immunotherapy, and probably chemo plus targeted therapy is better than the dual agent or probably the triple agent chemotherapy. So how do we use chemotherapy in the treatment of esophageal cancer? It may be used in the palliative setting, and may be used in the neoadjuvant setting, as definitive in the definitive setting as well, or as in the adjuvant as chemotherapy. So let us start from the least controversial part, that is the palliative chemotherapy. Definitely in the advanced or advanced inoperable or metastatic setting, we can, as I have already stated, the best try would have been triple or double agent chemotherapy. If not possible, then we have to go for single agent chemotherapy. So efficacy wise, cisplatin and 5-FU combination with immunotherapy has provided the best overall survival as per keynote 590. This is just an interim evaluation with PFS of 6 to 9 months, especially in squamous cell carcinoma. If we compare this newer therapeutic regimen with the triple agent, cis 5-FU and DOSI, we find that overall survival is almost 11 months. And if you ask me, probably immunotherapy is not that commonly used in our practice because of obvious logistic problems. So we are not doing a very bad job if we give triple agent to the patients, giving a comparable overall survival for almost 1 year in first line palliative setting. Dual agent chemotherapy provides an overall survival almost 9.4 months, but single agents definitely they fare not that well in comparison to the combinations. But we have to always keep in mind the choice of chemotherapy depends on the age, the performance status of the patient, as well as the comorbidities. As well as we have to always remember the interactions that chemotherapy has with other drugs. So for older patients or poor performance status patients, monotherapy is always preferred rather than combination therapy. This is the NCCN guideline, and as you have seen, targeted therapy along with combination chemotherapy is the standard of choice, and wherever we can incorporate, we should incorporate immunotherapy. What about second line? It won't surprise many that the standard of care in second line is immunotherapy now. Only if immunotherapy is a patient is not eligible for immunotherapy, only then we can go for chemotherapy. But once again, I would say that dual agent works almost comparably better in comparison to single agent here once again. And maybe for in our setting, dual agent is a good choice, as we can't provide patients with immunotherapy because of obvious logistic problems. We shouldn't forget that palliation, in palliation dysphagia, the problem of dysphagia will always be there with esophageal cancer, and we should try to palliate the patient, and probably this will provide the maximum benefit. What about neoadjuvant therapy? Neoadjuvant, we can consider for neoadjuvant chemotherapy or neoadjuvant concurrent chemo radiation therapy. And the controversy, as we all know, the controversy will always be there. Fortunately, that is not the point of discussion for us today. But whatever it is, chemotherapy comes in both the planning modules. So I'll just try to touch upon the fact that chemo radiation will always be considered better than radiation. The RTOG 8501 by Cooper et al. Definitely, Cooper tried it with definitive chemo radiation in his article, in his study. But this was the first study that proved that chemo radiation is a very good modality for patients with locally advanced esophageal cancer. And probably this study gave the idea that we can use chemo radiation as neoadjuvant therapy. Definitely, it improved the overall survival. It showed that 26% 5-year overall survival. Similarly, neoadjuvant chemotherapy was also considered, and it was found to be better compared to surgery only patients. Squamous cell carcinoma patients probably fared not that well in comparison to adenocarcinoma esophagus patients. But we found out that patients who could undergo R0 resection after neoadjuvant chemotherapy, only these patients had achieved the neoadjuvant chemotherapy benefit. Those patients who couldn't undergo R0 resection later after neoadjuvant chemotherapy, they had no benefit from this extended regimen. So ultimately, the concept of neoadjuvant chemotherapy in squamous cell carcinoma will always remain controversial. Obviously, if the patient achieves pathologic complete response, overall survival will always be more. But in otherwise, the concept of neoadjuvant chemotherapy in squamous cell carcinoma will remain undefined, at least for this present moment. In adenocarcinoma, however, OS and DFS benefit has been achieved with ECF chemotherapy as well as the newer FLOT chemotherapy. And the clinical evidence for association and the benefit of neoadjuvant chemotherapy or chemoradiation therapy was also analyzed by meta-analysis, new EC study, and it has found that both neoadjuvant chemoradiation as well as neoadjuvant chemo both conferred benefit compared to surgery only. Neoadjuvant chemotherapy worked better for squamous cell carcinoma, whereas neoadjuvant chemo worked better for adenocarcinoma. This is just a repetition, but this is the most important trial, the CROSS trial, which proved that NSCT-RT will always be considered superior to surgery alone cases. But we have to always remember that the CROSS trial took only 8 centimeter long tumors and 5 centimeter thick diseases. What about tumors more than 8 centimeter long or more than 5 centimeter locally advanced diseases? Probably we have to extrapolate data from the CROSS trial. Several other studies have also been done, and they have proved that NSCT-RT fares better. Definitely NSCT-RT, different combinations have been tried. CROSS trial used paclitaxel weekly, and neo-ERT used vinorelbine cisplatin. Whatever the regimen, NSCT-RT works. NCCN has included NSCT-RT as the standard of care in their guidelines, removing NSCT, neoadjuvant chemotherapy, for squamous cell carcinoma. What about definitive CTRT in locally advanced inoperable C esophagus? Definitely Cooper et al. Has provided the first evidence, and definitely NSCTRT followed by surgery will be better than definitive CTRT as stated by Barbeta et al., especially in stage 2 and 3 squamous cell carcinoma. But where probably because of comorbidities or the performance status or because of varied reasons, surgery is not possible, we can safely go for definitive CTRT. CTRT, the chemo regimen commonly employed is cis-5FU. Now let us come to adjuvant therapy. Adjuvant therapy again may comprise of adjuvant chemotherapy or adjuvant chemoradiation. Whatever it might be, chemotherapy comes in both. And chemoradiation has been found to be effective for those patients, those who had R1 esophagectomy. Definitely it provides a better survival. What about adjuvant chemotherapy? The JCOG 9204 trial proved that 2 cycles of cis-5FU within 2 months post-op provided DFS benefit, but specifically in node positive cases. Node positive cases probably had a trend for improved survival, but not in node negative patients. This was again proved by Bart et al. And Spicer et al. Proved that adenocarcinoma esophagus also benefited from adjuvant chemo, specifically if those didn't receive any neoadjuvant therapy, and specifically if they had node positive disease. Complications following surgery is a problem in C. esophagus, and definitely it predicts worse survival. But even in these cases, if we utilize adjuvant chemotherapy, they have found to improve survival. The recent trend being adjuvant nivolumab in resected esophageal or gastroesophageal junction cancer, especially in those patients who had residual disease following chemoradiation. So if I would like to conclude, the realization that esophageal cancer, like all other cancers, specifically breast cancer, is now a systemic disease. So we need systemic therapy for the same. We have to tackle 2 separate histologies, and so our planning should include. We should also consider histology specific planning. Combination chemotherapy provides the best benefit in any setting. If I may consider the worst case scenario, adding targeted therapy always will provide further benefit, but above all, proper palliation of symptoms should be stressed at all levels. Thank you. I thank all the organizer for providing me the opportunity for the same.
Thank you, Dr. Duncan. You have very nicely summarized and comprised it, because it is a elaborate thing and very controversial too. Thank you very much.
Thank you, sir.
We'll go to the question for the after finishing the next speakers. We are running out of time. So I will request our Dr. Vikas to take over for the next speaker. Okay, the next speaker is Dr. Parthapratim Medi, who is the assistant professor on radiation oncology, Department of Radiation Oncology, Dr. B. Borua Cancer Institute. He will be speaking on the radiation therapy in esophageal cancer. And okay, radiotherapy in esophageal cancer, the current evidence. Okay, I request Dr. Parthapratim Medi to go ahead.
Good evening, sir. Am I audible?
Yeah, yes, you are very well.
Sir, I'm sharing my screen. Please let me know if it is visible.
Okay.
Yes.
Sir, is it visible?
Yeah, it's visible.
It's visible, but not full screen. Jagtap, I think the same problem has existed.
Now?
Make it a
No,
slide.
sir, now?
Yeah, now it's okay.
It has come now.
Yeah,
It has come. Okay.
Please go ahead.
So, good evening, everyone. First of all, I thank the office bearers of Association of Oncologists of Northeast India for giving me this opportunity to speak on radiotherapy in esophageal cancer, the current evidence in today's conference. So I'll start my talk now. The role of radiotherapy in esophageal cancer is in a neoadjuvant setting, definitive, adjuvant, and also for palliative cases. But today we'll not be talking about palliative therapy. We'll focus mostly on the neoadjuvant and definitive aspects of radiotherapy in esophageal cancer. And I'll also not be speaking about brachytherapy because it is not a radical tool anymore in esophageal cancer management, and we'll focus mostly on the evidence of external beam radiotherapy. So in the 1990s to early 2000s, between this, it was around this time, the primary treatment of the primary mode of management of esophageal cancer was to go ahead with surgery first and then give adjuvant radiotherapy. But all the trials which were published from 1990s to 2003, they did not show any improvement in overall survival. It remained fixed at 10 to 20% despite giving different doses of adjuvant radiotherapy, and it only seemed to improve local control only without any survival benefit. So before that period, people had also explored the aspect of neoadjuvant radiotherapy with different dose combinations. As you can see from studies starting from 1981 to up to 2000s, the people have used various doses of radiotherapy along with as a neoadjuvant before going for surgery from 20 gray to 40 gray. But again, except in the last row, the study by Bhuyan, only that study showed a 5-year survival benefit of 20%. Otherwise, neoadjuvant radiotherapy provided only better local control, and there was no benefit of overall survival. And the doses, of course, in the neoadjuvant setting had to be lower than in the adjuvant setting. But from this exploration of the neoadjuvant radiation along with chemotherapy started from the 1980s, and it continued up to and it's still continuing actually. So this slide is from the famous meta-analysis by Stoquist, which was published in 2011. And you can see the studies they have listed from 1983 to 2004. And most of these studies have used a heterogeneous dose of radiotherapy from 20 gray, some studies up to 50.4 gray, and most of the studies use cisplatin 5-FU, except for the latest study by Vandergrast, the Netherlands group, who first used carboplatin paclitaxel along with 41.4 gray radiotherapy for both squamous cell carcinoma and adenocarcinoma during this period. And this famous meta-analysis that was published in 2011 in the Lancet Oncology. What is strikingly it is shown here is that there is a hazard ratio of 0.78 in this forest plot, strongly in favor of chemoradiotherapy in esophageal cancer prior to surgery. And the key learnings that we take home from this meta-analysis is that neoadjuvant radiotherapy reduced all-cause mortality for both squamous cell carcinoma and adenocarcinoma. Chemotherapy also reduced overall mortality, but it was significant only for adenocarcinoma subgroup and not squamous cell carcinoma patients, the type that we mostly see in the Northeast population. And a trend for reduced mortality with neoadjuvant chemoradiotherapy was observed over NSCT alone. So we come to the results of the cross trial. That is the famous trial from the Netherlands group, which has been published from 2012 till 2015 in various updates and analyses. And this trial included 368 patients with resectable tumor who underwent randomization, 178 in the NSCT-RT followed by surgery arm and 188 in the surgery alone arm. 75% of the patients were adenocarcinomas, and I have already mentioned about the chemotherapy and radiotherapy regimen that was used by the Van Hagen group. And after 41.4 grade radiotherapy and weekly paclitaxel for 5 cycles, the R0 resection rate was improved as compared to surgery alone. It was 92%, and there was a pathological complete response of 30% seen in these patients. This improvement in R0 resection and pathological complete response also was shown in the 5-year overall survival, which was seen to be for after many decades. There was a trial which has shown a overall survival nearing 50% in locally advanced or T3 squamous cell carcinomas or node positive squamous cell T3 or node positive esophageal carcinomas, both squamous and adeno. And when there was a subgroup analysis by tumor type and treatment group, it was seen that the benefit was seen for chemoradiotherapy for both squamous cell carcinoma and adenocarcinoma group, and but the benefit was higher. It was more than 50% for squamous cell carcinoma subgroup. And the postoperative mortality and morbidity was similar in both the arms. So based on this results of this trial, now NCCN recommends that for except for very low risk lesions like low risk lesions which are less than 3 centimeter or well differentiated, all patients, the category 1 recommendation for adenocarcinoma as well as squamous cell carcinoma should undergo preoperative chemoradiation if unless it is contraindicated or it is not, it cannot be practiced. Similar is for squamous cell carcinoma. All high risk lesions from T1 to T3 and 0 to N3 should undergo preoperative chemoradiotherapy if it is in a non-cervical location. So now we move to definitive chemoradiation in esophageal cancer. What about those candidates who are not fit for surgery and who will not? Should we? So what do we do with them? So they are the candidates we should give definitive chemoradiation therapy. Patients like T4B having T4B disease who are resectable but medically unfit for surgery, or patients who decline surgery. Radiation alone is often associated with poor outcomes in esophageal cancer, as we have seen in the past. So a combined radiochemotherapy regimen improves survival, and the dose of definitive radiotherapy in esophageal cancer, but there is no controversy regarding the management of cervical esophagus. The dose is 60 to 66 gray. But for thoracic esophagus and G-junction lesions, this has been a controversy for over decades. What should be the dose of definitive chemoradiation? Should it be 50.4 gray, or should we treat it like a squamous cell carcinoma of the head and neck, or non-small cell lung carcinoma, where we go from 60 to 70 gray? So the first answer we get from about this raging debate is from the RTOG 8501 trial by Cooper, published in JAMA Oncology in 1999. They randomized 121 unresectable cases of esophageal cancer with squamous and adenocarcinoma T1 to 3 and 0 to 1 M0 to chemoradiation versus radiation alone. The chemoradiation alone group received 64 gray radiotherapy. The chemoradiation group received 50 gray lower dose with 1000 mg 5-FU for 4 days and cisplatin 75 mg for first day on week 1, 5, 8, and 11. The radiotherapy target volume planning was 2-dimensional, and they used large margins of 5 centimeter to the primary tumor, and they also included the supraclavicular fossa for tumors in the upper and mid thoracic esophagus. So this trial showed that the the recurrence rate was higher when radiotherapy was prescribed alone, even at 64 gray, and when it was combined, 50 gray radiation was combined with chemotherapy, then the local failure rates were lesser. And the most striking result is that none of the patients who received RT alone were surviving at 5 years follow-up. At the 5-year survival was 0% in the arm, and it was 28% in the CTRT arm. So it was concluded that CTRT was better than high-dose radiotherapy alone in esophageal cancers. Then came the intergroup 0123 or RTOG 9405 trial, which was published in JCO in 2002. They randomized 236 cases of T1 to T4 and 0 to 1 M0 squamous cell carcinomas and adenocarcinomas of esophagus to a high dose of radiotherapy, where they delivered 64.8 gray in 36 fractions in one arm versus standard dose, which was the 50.4 gray in 28 fractions in the other arm, along with chemotherapy. So here the chemotherapy arms were similar. Both the patients in both the arms received same chemotherapy, except the radiation dose was higher in the second arm. Again, the conventional planning was used with large field borders of 5 centimeter superior inferiorly and 2 centimeter radial margins. If we look at the results of this trial, it is even more shocking. We see that there were 11 deaths as compared to 2 deaths in the high dose arm, and these were initially attributed to treatment related deaths, but later on it was clarified that 7 of the 11 deaths in the high dose arm occurred in the patients who had received radiotherapy 50.4 gray or less. That means before they reached the higher dose limit, they had death. So this may not be associated to this treatment related mortality, but if we look at the results, the higher dose radiation did not increase survival or local regional control either at 2 years, 3 years. So the standard radiation dose for patients with high definitive chemoradiation in esophageal cancer was fixed at 50.4 gram with concurrent cisplatin and 5-FU. But what are the fallacies of this trial? They used outdated radiotherapy techniques with 2-dimensional margins, two-dimensional planning, large margins, and but nowadays we do not use. We use CT-based planning. We do 3D CRT, IMRT. We plan our GTV. We can see our gross tumor volume in the CT scan. Trim our margins according to the whether they are encroaching. If they are, and suppose for this, if when we are using a 1 centimeter radial margin, the part that is going inside the heart, which should not be in the clinical target volume, we can trim it so that our final planning target volume includes less amount of the normal tissues. Similarly, our superior inferior margins have come down to 3 centimeter now with evidence. Based on this, now we have a target volume contouring guideline, which was published by Abraham Ju in IGRO BP in 2015. So, based on these expert findings, we have started doing 3D CRT and IMRT for patients, and we are controlling our radiotherapy spillage more and more with progression in radiotherapy techniques. So then post 2010, as you can see, all the studies that are published on this debate regarding high dose versus standard dose, they have used 3D CRT and IMRT techniques for radiotherapy planning. One amongst them is a study from BBCI, Bhuyan Cancer Institute, which was published in 2018 by Ravindra, and this has also been included in this first meta-analysis of high dose versus standard dose radiation in esophageal cancer. And surprisingly, this meta-analysis, which was from China, they found a survival benefit with high dose group, high dose radiotherapy, that is more than 60 gray, without any increased incidence of grade 3 radiation related toxicities. So again, there was a confusion till the July 2020 till 2021, when the results of the Art Deco study came. So Art Deco is the first mature randomized trial investigating the effect of radiation dose escalation in esophageal cancer. It used a PET-CT based diagnostic and therapeutic approach, modern non-conformal radiotherapy techniques, and they used the chemotherapy regimen which was used by the same Netherlands group in the cross trial, weekly paclitaxel and carboplatin. And after randomization of 130 patients in each arm, they found that the radiation dose escalation from 50.4 gray to 61.6 gray in definitive chemoradiotherapy for esophageal cancers did not result in an improvement in local control or survival. You see, both the curves are almost touching, and it is neither different for the squamous cell or adenocarcinoma. So the 50.4 gray dose remains the standard with acceptable logical, locoregional and survival outcomes. But the proponents of high dose radiotherapy, they say that 90% of the local failures in esophageal cancer occurred in the GTV after definitive chemoradiation in the with 50.4 gray BRT. And there was another study by Sharma et al. Who showed that post-treatment decrease in SUV in tumor associated with tumor of esophageal cancer was associated with local control and disease-free survival after definitive chemoradiotherapy. Thus, there was a need to boost the GTV with radiation doses, and then the approach of PET-guided simulation simultaneous integrated boost IMRT approach for dose escalation is being evaluated now. So this was a study published from China in the Green Journal in 2015. They evaluated the safety of dose escalation by using PET-guided SIB IMRT in esophageal cancer. And it's very interesting to see that what they have done, if that this is the gross tumor volume at before radiotherapy. So they have found out a area, this black area labeled as GTVR, where they are saying that GTVR is the volume of GTV which has an SUV standardized uptake value in the PET scan of more than 50% of the SUV max. So they consider that this is the most radio-resistant area. So what they do is after the standard dose, so they give the standard dose to the conventional margins, the gross tumor volume plus 3 centimeter. This receives the standard dose, but they boost the this black GTVR, which is the most radio-resistant part, by a 1 centimeter margin, and boost it in 4 different levels, up to 63 gray in some patients, and up to they have done it up to 70 gray, all in 28 fractions. So while this part of the volume is getting 1.8 gray per fraction, this part is getting 2.25 to 2.8 gray per fraction. And they have demonstrated that this approach is safe and is well tolerated, and there was no treatment-related grade 4 and 5 toxicities. And this has also been done in a randomized phase 1, phase 2, in a phase 2 trial by the MD Anderson group, and they also showed that SIB IMRT reduced local failure rates in node-positive patients, adenocarcinomas, and stage 3 to 4 disease. Next is the proton beam therapy, as the India has also got its first proton beam therapy unit in Apollo, and maybe in the future we'll see more and more coming up. But so this is the, if you can see the this is the dosimetric benefit of proton beam therapy. This is from 3D CRT dose profile. This is the IMRT dose profile, and this is a proton beam dose profile. You see there is very or almost no dose received by the heart. So does the dosimetric benefits of proton beam actually translate into improved survival, or improved benefits? This was compared in the first it was the first clinical outcome published in the JCO in 2020, and they showed that at 44 months of follow-up, the 3-year progression-free survival and 3-year overall survival rates were similar for both proton beam therapy and IMRT, but there were lesser toxicities and fewer post-operative complications with proton beam therapy in esophageal cancer patients.
Arthur, you have 1 more minute.
Yes, sir. I'm concluding in 2 minutes. 1 minute, sir. So the next is the scope of MR-guided radiotherapy. So the MR linac provides with a unique adaptability based on daily changes in the shape, size, and position of the tumor. We can do an online adaptation of the target volume and online replanning. That means when we during the treatment, if we see that the volume has shrunk down, we can contour the tumor again and do plan the radiation for that fraction on the same in the same treatment unit, and also monitor the tumor motion during treatment. This has reduced treatment-related toxicities. This has the scope of reducing treatment-related toxicities, and therefore there is a scope for target dose escalation in esophageal cancer using MR-guided radiotherapy also. So to summarize, all resectable esophageal cancers except T1 and select T2 should receive neoadjuvant chemoradiation prior to surgery because it has shown improved survival. Definitive chemotherapy in unresectable esophageal cancers is the answer, but the current evidence is in favor of giving 50.4 gray external beam radiotherapy with concurrent chemotherapy, which may be cisplatin 5-FU or even paclitaxel carboplatin weekly. And RT dose escalation to primary tumor up to 63 gray or above for better local control and survival in patients receiving definitive chemotherapy is still a subject of ongoing research. We'll have to wait for the results of the other studies like ART-DECO to come up. And SIB IMRT may help this, may be the next step in this direction. And proton beam therapy and MR-guided radiotherapy may be the potential game changers in this aspect. Thank you.
Thank you, Dr. Pathak. It was a very nice and elaborate presentations.
Thank you, sir.
So I request Dr. B.C. Goswami is there or not?
I am here. And we thank all the three speakers for excellent presentation. Unfortunately, we don't have much time for discussion, but I think we can devote some 10 minutes of time for question and answer.
Any questions?
So if there is no question, then I can put forward one question.
There are some questions in the chat box. I think the first can be taken up by Dr. Abhijit. What would be the preferred approach to administer the neoadjuvant treatment for locally advanced esophageal squamous cell carcinoma, and why there is a heterogeneity in the clinical practice? So what should be the way? Either it should be neoadjuvant CTRT or it should be NACT only.
For squamous cell carcinoma, can I?
Yeah, please.
For squamous cell carcinoma in the institution, we practice neoadjuvant chemo-RT, and we have experience of almost 75 cases. So we have seen that interoperatively we have used minimal invasive approach also, because most of the predominant cases we are doing VATS for the thorax mobilization and for the lymph node dissection. We have not found any like lung fibrosis or planes being distorted with the help of VATS also. So I think for squamous cell carcinoma, neoadjuvant chemo-RT is the approach to go. Because heterogeneity is there, it is difficult to apply, because there needs to be a lot of patient counseling, because for the patient, it is not the what modality being used. He has to be counseled that each step is important, because when we use neoadjuvant chemo-RT, we are giving 40 gray. So if that patient, when he has a response, loses for follow-up, the whole purpose of treatment gets defeated. So there has to be a proper counseling, then only we can use a neoadjuvant chemo-RT across the spectrum.
Yes. And the second question is also, I think surgeon can answer, is in most of the cases, CT scan thorax reports as the contact with the abdominal aorta is more than 90 degree or less than 90 degree. How is it related to the resectability of the primary disease?
So if we have a contact which is more than 90 degree, it indicates that it is a T4B disease. So which we don't treat with surgery. Whereas if it is a limited esophageal involvement that is less than 90 degree, so there we can see potentially resected. So where we will use our neoadjuvant strategies to downstage the tumor.
I think because of the time, we'll not be able to take the question round. Maybe we can have the questions later on if the speakers are there. Antia, please go ahead.
I want to thank all the chairpersons for this session. I also want to thank all the speakers for all the I would also like to thank all the speakers for the wonderful sessions they've taken. I would like to hand over this further proceedings of the session to Dr. Vikas Jagtap. Thank you, everyone.
Yeah, thank you, Antia. Thanks to all the chairperson and all the speakers. I hope you continue in the conference so that if any time permits, we can ask the questions which are not been answered on the chat box. So without wasting much time, we'll go ahead with the next session. Our next session is on the breast cancer. And for that session, we have a chairperson today with us, Dr. Noor Topno. Dr. Noor Topno is the professor and head in the Department of Surgery, General Surgery at NIGRIMS Shillong. And Dr. Zhotan Kima. Dr. Zhotan Kima is the radiation oncologist. He is also the in charge of Regional Cancer Center in Aizawl, Mizoram. I hope both are there. Topno sir?
Yes, I'm there.
Yeah, Dr. Kima, you are there?
Yes.
Yeah, thank you. So all the speakers are there. All the judges, chairpersons are there. So I hand over to the chairperson to start the session. Thank you.
All right, then thank you. Since the first talk is a surgical one, I just take over. And just for the speakers, just to remind you, your talk is 15 minutes. Try to please stick to the time. And all the question answers will be at the end of all the talks which are there in this session. So the first speaker here is Dr. Palomi Mukherjee, and he's from the Kachar Cancer Center. He'll be talking on approach to lymph node dissection in early breast cancer. It's definitely an interesting topic lymph node dissection in early breast cancer. So I hand over the stage to Dr. Mukherjee. You may please begin your presentation.
Thank you very much, sir. Am I audible?
Yes, you are audible.
Yeah.
Yeah, I'm sharing my screen.
Yes, your screen is not yet visible.
Yeah, just give me a minute, sir.
Yep, no problem.
Yes, you are visible, Polomi.
Right, I'm visible. What about my screen? Is it?
Screen is not visible.
Screen is still not
No,
visible.
you're
Okay.
You are sharing
Get
the
the
screen.
One second, just a second. Just a second. All right. Right, here we are. Share. Is it okay now?
Starting. Yeah. Okay.
It's
You can-
started?
Visible, ma'am. Can you put it on presenter mode?
Yeah, just give me a minute. Yes, sorry for the delay. So we are discussing about the approach to lymph node dissection in early
Ma'am,
breast
sorry to
cancer.
interrupt you. Your
Yes.
screen, your slide is not in presenter mode.
I'm sorry.
Make
So
it complete.
what do I have to do about that?
Ma'am, can you see 3 icons
Yeah,
on right bottom?
yeah,
The
right
icon.
bottom. No, all my icons are right up.
You just continue, Polomi. That's fine. I think you can
Okay.
just go to next screen.
All right. So the risk factors for lymph node involvement in breast, why are we so concerned, is the axillary lymph nodes, they receive 85% of lymphatic drainage from all the quadrants of the breast. And the remainder drains to internal mammary, infraclavicular and supraclavicular lymph nodes. So whatever surgical management, regional surgical management, be limited to the axilla, because a lot of previous, a lot of surgical trials have shown that even if we aggressively clear the internal mammary infraclavicular areas, this does not really lead to an enhanced survival as compared to a more conservative surgery. So what does the axillary node metastasis depend on? Number one is the tumor size. So here we can see.
Polomi, your screen, next slide is not coming.
Next slide. I'm talking about this.
No. You are started the next slide. We are still.
No, I
showing the-
haven't. This is my
Okay.
first slide.
Okay.
Can you see these risk factors for lymph
No.
node involvement?
The second slide is not visible.
It's not visible. What about this?
No.
Can you click on this number 2 slide?
Okay,
From
this
out?
is the number 2 slide.
We can't see it, ma'am.
We can't see.
Okay, so what
Still
can you
coming
see?
first slide.
Oh, it's not.
Can you
moving.
reshare your slides, ma'am? Can you reshare your slides? I think this will resolve the
Okay,
problem.
okay, I'm going to stop sharing and. Okay, I've stopped sharing.
Yeah.
All right. Now what do I do? Start sharing again?
Yeah,
Okay.
you have to share it again.
All right. Share screen. Okay. All right. Okay.
Just go to next slide.
Can you click on the number 2 slide?
Number 2 is this. Okay.
Yeah.
Okay.
Okay. Now
Is
just
it moving?
Yeah.
All right.
Yeah, slide has moved.
All right. So if I go back, if I go to the slideshow, this will probably not moving. So shall I just present in this mode?
Yeah,
Should I
yeah.
just-
Present in this mode, there's no problem.
All right. Is it moving right now? No.
Yeah, we're seeing the second slide, just click
Okay.
back and forth.
All right. So maybe we just present in this mode. Is that all right?
Yeah, that's fine.
Is that all right? Okay. So what we can see here is a tumor size of less than 2 centimeters, something around T1A or T1B or C, that has a significant chance of lymph node metastasis. So therefore, addressing the axilla in whichever way is extremely important, especially making sure that you are not missing out a local regional metastasis. The next is the histological features. A grade 1 disease with similar size will have a risk ratio of a percentage of 3.4 versus 21% in tumors which are grade 3. Hence, when we look at tumors that's associated with less than 5% risk of lymph node mets, we have just a handful. That is tumors with a single focus of microinvasion, tumors that are less than 5 millimeter grade 1 tumors without lymphatic invasion, pure mucinous or pure tubular carcinomas that are less than 1 centimeter. And in all these cases, we might probably be a little less aggressive about managing the axilla. Then again, the tumor location, the axillary lymph nodes are more commonly involved. The ones that involves the axilla are situated on the lateral side rather than medial portion, but most commonly, the 85% of the tumors in all the quadrants of the breast would drain to the axilla. Now, one of the most important areas is the assessment of axilla prior to a surgical or an interventional procedure. Physical examination, though very important to pass an exam or evaluate a patient in the clinic, does not contribute much to the findings. For example, your positive predictive value of a physical examination is only about 61 to 84%. The negative predictive value is further dismal at about 50 to 60%. So what we do instead is we make use of an axillary ultrasound, and this with the help of an ultrasound, we have guided FNACs or core biopsies, and this identifies the patient who are candidates for lymph node dissection if they turn out to be lymph node positive, versus a sentinel lymph node biopsy where preferentially you need to have a clinically negative axilla. So in early breast cancer, the assessment of axilla, the gold standard once upon a time was axillary dissection, but we know we have moved on to less radical, more conservative approach. So the current standard of assessment of the axilla is with the sentinel lymph node biopsy. We will be speaking about sentinel lymph node biopsy in the subsequent slides. So sentinel lymph node biopsy is the current standard of assessing the axilla in early breast cancers. So what the sentinel lymph node biopsy, see a clinically negative axilla by palpation and ultrasound examination may have a pathological node positive rate decreases to approximately 18%. So it's still not 0%, and hence this role of sentinel lymph node biopsy comes in a clinically negative axilla. So again, to emphasize the preoperative axillary evaluation, you need to have a clinically positive node would undergo an axillary lymph node dissection, and hence you need to have an ultrasound guided FNAC or a co-cut biopsy to make sure the axilla is clinically node negative. The ones who are clinically node negative would be candidates for sentinel lymph node biopsy. So here again, very definite indications for sentinel lymph node, early breast cancer with clinically negative axillary node. DCIS, this I have to mention because with planned mastectomy or suspicious features. Now we know that in an in situ carcinoma, there's absolutely no chance of axillary metastasis. But in these group of patients who are planned for mastectomy, the specimen may harbor an occult site of invasive carcinoma or certain DCIS with suspicious features of invasive disease like a DCIS more than 5 centimeter or a DCIS with a palpable mass. So these are the situations where we would like to do a sentinel lymph node biopsy in patients when we are planning them for surgery. So in these patients, apart from our regular, the regular tracers, we have the super paramagnetic iron oxide. I'll be describing it in my subsequent slides. The contraindications to a sentinel lymph node, again, clinically positive nodes, they are not candidates for a sentinel lymph node biopsy if you knew beforehand the patient is clinically node positive. Inflammatory breast cancer, because in these patients the lymphatics are different and the sentinel lymph node is not, there are very high chances of false negative. So these are the two absolute contraindications. The others, like a locally invasive breast cancer, is a relative contraindication because in large tumors, you may sometimes have a node negative disease, which in turn may prompt the surgeon to do a sentinel lymph node biopsy. Though I would like to reiterate that the classic trials that has been that are the hallmark as validation, as well as sentinel lymph node, that has helped us form this guidelines for sentinel lymph node. They have not included any tumor that is higher than T1 or T2. So if you want to do a sentinel lymph node for a T3 disease, that would be a little, it may not, you cannot take whatever's happened in the trial conclusions, and use it for your conclusions when you're using it for a relatively larger tumor size. But there are other studies that have reported the safety for using it in larger tumors larger than T1, T2, that is given safe, oncologically safe outcomes. So this is one relative contraindication for SLNB. Again, it should be omitted in patients whose axillary status does not guide adjuvant therapy. So if you have patients, elderly ladies, ERPR positive receptor status with a small tumor, so in their cases, studies have shown that sentinel lymph node does not really contribute to much, and they can be safely put on hormone therapy after lumpectomy. So in these patients, again, they have to be discussed in a tumor board, and of course the patient's decision needs to be taken into consideration. But yes, you could consider omitting SLNB in these group of patients. The techniques for the sentinel lymph node. Now, the evidence suggests that the entire breast drains to same few sentinel lymph node regardless of the injection site. Now, this is the premise based on our entire sentinel lymph node biopsy exercise. So we all know that this was first introduced by the by the cancer surgeons Giuliano and Craig in 1993-94. Now, it typically begins with the injection of 1 or 2 tracers into the breast skin or parenchyma, either in the vicinity of the tumor or under the areolar plexus. Now, in this context, you have to remember that if you are injecting the dye in a previously excised in a patient who's had a lumpectomy, so make sure you do not inject it into the seroma or directly into the cavity. Typically, this has to be injected into the wall of the cavity instead of directly into it. And these tracers enter the lymphatic channel and passively flow to the draining lymph nodes. Sentinel lymph nodes are then identified as those first receiving drainage from the tumor by the presence of tracer and removed. So this is the very basis of the sentinel lymph node technique that we use. The blue dye was the first agent that was used for identifying sentinel lymph node, and isosulfan blue is a very commonly used dye, and this is either injected around the tumor periphery or the palpable edge of a biopsy cavity or in a subareolar plexus. Following the injection of this dye, the breast should be massaged for 5 minutes. This is to facilitate the movement of this dye into the lymphatics and into the axilla. Then we have a careful and systematic search is made for the blue lymphatic channels. Now, if we are using only the blue dye method, it is very important to note that sometimes the channel may end in a lymph node that has not taken up the blue dye. But the whole idea, the way to execute this is you follow the blue lymphatic channels, and if it ends or if it leads you to the lymph node, irrespective of the color, that has to be excised and sent for pathology. So in this regard, we have to be very careful about tracing the lymphatics. Also, what is important is you have to be very careful of the factor that this dye quickly washes away. So if there is a delay of executing the axillary part of the dissection or executing the opening up the axilla, we might sometimes find that the nodes they have not taken up or the blue dye has washed away. So that the time factor is very important. The second most important is the radioactive colloid, and this material may be injected peritumorally, intradermally, or the subareolar plexus. Again, the one that we use is technetium sulfur colloid. The half-life is 6 hours, and typically 0.5 millicurie is injected on the day of the surgery, or if you're doing it the day before, the dose is about 2.5. Now, the same, the breast is massaged to facilitate the lymphatic drainage. The handheld gamma probe is used to identify the maximum radioactivity in the axilla. The axillary skin is made over the hotspot, and the node is harvested. Now, the lymph node with the highest radioactivity is determined by with the gamma probe. That is the one that's first removed. The ex vivo count is obtained, and the removal of the subsequent lymph node follows a 10% rule, which essentially means that all the nodes that have about 10% of the count of this, the first node or the highest, the one with the highest radioactivity, are all harvested. Now, having said this, the optimal number of nodes in the study has been about 3, because what the study has shown that anything more than 4 has not really has not really given us the proper sentinel lymph node. So your sentinel lymph node is actually picked up in the first 3 to 4 nodes that you harvest, provided you follow all these steps very carefully. Now, this is going to, and following the steps will also ensure that our false negative rates are reduced. There are other investigational techniques, which includes the very current indocyanine green. Now, here the sentinel lymph nodes are localized using a fluorescent imaging system. Then we have the super paramagnetic iron oxide. Again, these nodes are localized using a magnetometer. Now, the characteristic of this particular tracer agent is that it stays in the channel for up to a month. So it gives us an advantage in cases of DCIS where you are planning to take up the patient if the node is positive, or in case there is an invasive component in the specimen submitted, we plan to take up the patient as a second stage. So in this case, this particular tracer agent remains in the lymphatic channel, and it aids a sentinel lymph node biopsy as a second setting. So because post mastectomy, what we are worried about is the channels, the lymphatic channels may be, there may be a change in the lymphatic channels, and we may not get the correct sentinel lymph node. But in this case, since the tracer stays in the lymphatic channels for about a month, it greatly facilitates sentinel lymph node as a second stage procedure. Then there's a very current microbubble. Sorry?
Time is already over, so we can just speed up a little bit.
Okay, so microbubble contrast agent. So most importantly, I'll just go to the single versus dual technique. Now, this is important in to reduce this is important to reduce the false negatives, and most importantly, where in cases of neoadjuvant therapy, in cases where patients had prior breast or axillary surgery, or the patient is obese, this particular dual technique gives us a higher positivity rate. All right. So certain special circumstances, I'll just make a flying mention. Neoadjuvant chemotherapy, it's currently various studies are coming for this. Multicentric disease. Now, the reason these are special circumstances because not all institutes, they favor sentinel lymph node biopsy in these cases, and we don't have very pressing evidences. So previous breast and axillary procedures for extensive benign conditions. Previous breast and axillary for, again, procedures like augmentation, mastopexy, etc. Recurrent breast cancer and previous axillary surgeries, male breast cancer and pregnancy. Because of lack of time, I am not elaborating on this. The only thing is, in the pathological analysis of nodal metastasis, macro metastasis is the only where the tumor's deposit is more than 2 millimeter, are the ones where we consider them as true sentinel node, and our decision to do a completion axillary dissection is based on this. Isolated tumor clusters or micrometastasis does not really contribute to decision making. Also, if we find an extranodal disease, this is where we straight away proceed for a completion axillary dissection. Axillary nodal dissection in early breast cancer, I would just this is the only indication for axillary dissection without a sentinel lymph node in locally advanced breast cancers or inflammatory breast cancer. And number 2 is needle biopsy proven metastatic disease in axillary lymph node, which are neither clinically palpable or non-palpable, but abnormal by imaging. Now, there is just a group of women who are exceptions to an axillary dissection, that is women with estrogen receptor positive T1, T2 tumors that are clinically node negative with fewer than 3 positive sentinel lymph nodes who would be treated with whole breast radiation. So these are the women who do not, despite being less than 3 positive sentinel lymph node, we don't proceed to do axillary dissection. So this is just my last slide. So this is how we proceed for our evaluation of the axilla in early breast cancer. You have a palpable axillary node. You can do an FNA by palpation because, like as I said, clinical examination is not very contributory. If it's negative, you take up for SLNB. If it's positive, you do an axillary dissection. Non-palpable nodes, we again utilize the ultrasound. If it's suspicious, we go ahead and do an ultrasound guided FNAC, and likewise, if it's non-suspicious, they can straight away be taken up for sentinel lymph node biopsy. So thank you very much, Vikas.
Thank you.
Thanks.
Okay, thank you, Dr. Purohit. I think the only problem was the build-up of your talk took a little long.
Okay.
And judging by the slides that we saw, I'm sure we would have enjoyed the rest of your talk if we had the time. Hopefully, in the question and answer session, we may be able to take up some of the issues that came up as a result of your talk. So for the next talk, I think I'd hand over to Dr. Zothan, because the next talk is also on a radiation-based talk. So Dr. Zothan, please.
Thank you so much. Thank you so much. Our next topic is on an approach to the lymph node irradiation in breast cancer. And may I invite the speaker, Dr. Naveen Narayan, who is an assistant professor from the Department of Radiation Oncology in NECRIMS, to present his paper.
Am I audible?
Yes, yes. Please carry on.
Can I share the screen from my side?
Naveen, I think it's better that you continue here only because it will be difficult. Again, there will be issue. Ravindra, just continue sharing from our side only. Naveen, you can just ask them to go to the next slide in between. Okay.
Okay.
Thank you.
A very good evening to all my respected teachers, colleagues, and my friends. Today I'm here to talk on approach to lymph node irradiation in breast cancer. Next slide, please. So I'm going to touch upon the introduction part. What is the RNI? That is regional nodal irradiation. What are the indications? NCCN guidelines. What is the evidence for RNI? What should be the target volume? Techniques and role of RNA in special circumstances. Next slide, please. So coming to the introduction, as all of us know, radiation therapy is an integral part of multimodal management of breast cancer. And the radiation provides a significant local control and long-term survival benefit in patients who undergo breast conservative surgery and in those with locally advanced breast cancer. The appropriate extent of radiation therapy volumes and whether this should include regional lymph nodes, however, remains a topic of debate. A primary objective of regional treatment for breast cancer, whether surgical or radiotherapy, should be to eradicate macro or microscopic disease within the lymph nodes, reduce the risk of locoregional recurrence and distant metastasis, and confirm a survival benefit. Next slide, please. So basically, regional node irradiation is the irradiation of the axillary, supraclavicular, and internal memory regional lymph nodes. However, there is a contrast between the clinical practice and the evidence and the guidelines. These are the pictures depicting the different level of lymph nodes. Next slide, please. So conventional indication for radiotherapy to regional lymph nodes definitely include 4 or more new nodes positive, inadequate axillary dissection, node positive with extensive extracapsular extension, positive sentinel node or micrometastasis as an alternative to axillary lymph node dissection. Next slide, please. So if you see the NCCN guidelines, they also mention the comprehensive regional nodal irradiation in all the cases, whether it is a negative axillary nodes, 1 to 3 positive axillary nodes, or more than 4 positive axillary nodes after breast conservative surgery with surgical axillary staging. Next slide, please. And even after total mastectomy, there is mention of the addition of comprehensive regional nodal irradiation. Next slide, please. Next slide, please. So question is whether comprehensive regional nodal irradiation is needed. If yes, then to what extent? So definitely there is the evidence, there is the guidelines for the comprehensive regional nodal irradiation, but definitely toxicity is also associated with the comprehensive regional nodal irradiation. So we have to balance between this evidence and the toxicity to choose for the regional nodal irradiation in the breast cancer. Next slide, please. So in early breast cancer, the regional nodal irradiation evidence mainly came from the MA20 trial and the URTC trial. Next slide, please. So MA20 and the URTC 2292 trial evaluated the benefit of more extensive lymphatic treatment in patients with higher risk lymph node negative or the lower risk lymph node positive disease. A meta-analysis of these two studies suggested that the addition of RNA to the level 3 axillary, supraclavicular, and the upper internal memory lymph nodes conferred an improvement in disease-free survival and the distant metastasis-free survival, as well as 1 to 2% overall survival advantage. However, other studies have suggested that many patients with positive sentinel lymph node who are treated with breast conservation, including breast irradiation, may safely avoid the morbidity and the cost of further axillary treatment, whether it is the surgical or the radiotherapy. Both the surgical and the radiation is the local therapy. And my previous speaker, Dr. Plomi madam, has highlighted all the aspects of sentinel lymph node biopsy. Next slide, please. So this is the comparison table of comparing the MA20 and URTC 22922 trial. So you can see definitely there is a advantage in the disease-free survival and the distant metastasis-free survival, but there is no advantage in the overall survival. That is both in the MA20 trial, 82.8% versus 81.8%, and in the URTC trial, that is 82.3% versus 80.7%. And in the toxicity, especially grade 2 acute pneumonitis and the lymphedema is higher in the irradiated arm. Next slide. However, there is no long-term overall survival benefit after regional nodal irradiation. Next slide. In the majority of post-mastectomy radiotherapy trials, the target for RNI include the ipsilateral undissected axilla, the supraclavicular region, and the first 1 to 4 medial intercostal space. There is a greater degree of controversy over the value of nodal irradiation for patients with less nodal burden or high risk and zero disease. In addition, nodal irradiation had the potential to increase acute and late cardiopulmonary toxicity and lymphedema, especially after a complete axillary lymph node dissection. In the URTC AMROS trial, revealed that axillary radiotherapy to level 1, 2, and 3 after positive sentinel node biopsy provides excellent axillary control for patients with T122 primary breast cancer, even when axillary lymph node dissection is omitted. Next slide, please. Overall, the standard of care for patients with clinically unknown disease at diagnosis with persistent disease after NSCT includes comprehensive radiotherapy to the undissected regional lymphatics. However, there is a lack of certainty on how the effect of neoadjuvant chemotherapy will alter the effect of nodal irradiation on local regional control and survival benefit. There are 2 trials which is evaluating after the neoadjuvant chemotherapy. Alliance trial for patients who are sentinel lymph node positive after the NSCT, and the NSA-BP51 trial for those who achieve the complete pathological response in the partial complete response in the axilla. Next slide, please. So this is the algorithm that was published in the breast in 2017 for early breast cancer. So definitely in early breast cancer, if the patient is going for the breast conservative surgery and the sentinel lymph node biopsy, if it is negative or if it is positive with the low risk, there is no role of the RNI. But in the high risk or in the positive sentinel lymph node biopsy, definitely there is a nodal irradiation. And after the neoadjuvant chemotherapy, in the complete response or in the N1 disease, better to be enrolled in the clinical trial. And in higher nodal burden, there is a role of regional nodal irradiation. Next slide. So again, the sentinel lymph node biopsy cases, if there is a negative and if there is no axillary lymph node dissection, there is no RNI. This is the ESCO guidelines published in the JCO in 2021. But in the micrometastasis and the macrometastasis, there is a role of RNA. They have highlighted it. Next slide, please. So now what should be the target volume? Because in the clinical practice, some target the supraclavicular region only, some target the level 1 and 2 axillary lymph nodes only, and some targets all the 3. So what should be the target volume? This is the result of a network of meta-analysis. Next slide, please. So this they have meta-analyzed the both trial, MA20 trial and the URTC 22922 trial, who evaluated the whole breast or the chest wall irradiation versus whole breast chest wall irradiation plus comprehensive regional nodal irradiation. They have also analyzed the other trials which have compared the both arms, and there was the indirect analysis also. Next slide, please. So in this forest chart, you can see there is a favorable arm in the regional radiation, both in the indirect analysis and the URTC and the MA20 trial. Next slide, please. Again, in the disease-free survival, there is a favor in case of the regional radiation. Next slide, please. And in the distant metastasis too. Next slide, please. However, you can see in the overall survival, in the indirect analysis, this is completely in favor of the less regional irradiation, and also in the URTC and MA20 trial, there is not much advantage in the overall survival. So they have concluded as expanding the radiation field to the axillary apex and the supraclavicular nodes after axillary node dissection reduced locoregional recurrence without improvement in overall and cancer-specific survival. A prolongation in survival due to regional node irradiation is achieved when the internal memory chain is included. Next slide, please. So this is the field borders in the tangential field and the irradiation of the medial supraclavicular and the internal memory lymph node. Next slide, please. So this is the a figure of different fields covering the chest wall or whole breast and different levels of the lymph node. The internal memory lymph node can be included by the extended tangential field or in the separate electron portals, and in the level 1 and 2 can be covered with the high tangential field, and with the separate medial supraclavicular lymph node can be covered with the separate field. Next slide, please. So these are the guidelines also. These are the guidelines for the nodal contour for the different levels of the lymph node. Next slide, please. Now, what is the role of regional nodal irradiation after breast conservative surgery for the early HER2 positive breast cancers? This is a sub-analysis for the ALTO trial. Next slide, please. So trials demonstrating the benefit of regional nodal irradiation in reducing the recurrence was done in the pre-trastuzumab area. And when the targeted therapy, anti-HER2 targeted therapy came, there is a very less trials covering the role of RNI. And this is the result of sub-analysis from the ALTO trial, where out of 1,664 HER2 breast cancer patients, 878 received the RNA to the axilla, supraclavicular, and the IMAN nodes. At median follow-up 4.5 years, DFS was 84.3% in versus 88.3%. There is no difference in the regional recurrence, 0.9 versus 0.6%, or in the overall survival, 93.6 versus 95.3%. Next slide, please. So there is no DFS benefit of RNA regional nodal irradiation in HER2 positive, node positive patients treated with adjuvant HER2 targeted therapy. Next slide, please. Now, there is a question of whether we have to practice the hypofractionated nodal irradiation in breast cancer. Now, in the most of the center, we practice the hypofractionation while delivering the radiation to the whole breast or the chest wall. And there is a growing trend to extend the therapy's indication to nodal irradiation also. However, there is a very less assessment of lung and heart functions, and the use of different techniques may have confounded the real effect of vaccination. Until the new clinical trials prospectively study overall survival and the functional changes of critical organs, clinicians should take caution from extending hypofractionation to RNA. Next slide, please. Now, in the modern era, the surgery has become progressively less invasive, and the data supporting a larger role and the extent of nodal irradiation have grown. Ambrose and the AUTO-ASSORT trial demonstrated that axillary radiotherapy can be used as an alternative to axillary lymph node dissection in node-positive patients, yielding extremely low role of axillary recurrence and the less morbidity than the surgical resection. However, concurrent surgical trials evaluating the omission of axillary lymph node dissection in the absence of consistent nodal irradiation also reported excellent long-term outcomes. However, it is not clear that value of nodal irradiation applies equally to all patient subsets. Next slide, please. Now, coming to the consensus discussion of the Sant Gallen Vienna 2021, here I wanted to highlight they have consensus regarding RNA was declined for the patients with the TNBC or the HER2 positive breast cancer with pathologically proven complete response after neoadjuvant therapy. 89% voted with this consensus. And there is another point I have to highlight. This consensus has said the panel was very clear that genomic signature, oncotype DX, MAMA print, or prosigma cannot be used to help decide on nodal irradiation or the PMRT, neither of the omission of the radiotherapy. Next slide, please. So there should be the rational use of regional nodal irradiation is needed. MA20 and the UATC trial definitely shows the evidence that the nodal irradiation resulted in significantly improved disease-free survival, less distant metastasis, reduced breast cancer-related mortality, and the limited toxicity. However, the lack of statistical significant overall survival benefit and the increased risk of lymphedema, pneumonitis, and the cutaneous adverse event, the debate over the use of regional nodal irradiation is likely to continue. Regional radiation is a more complex, time-consuming, and the more expensive to deliver. The potential benefit of nodal irradiation might depend on the extent of axillary lymph node dissection achieved and the adjuvant chemotherapy. Therefore, rational use of RNA is needed, and this should be individualized case by case. Next slide, please. To summarize, irradiation of the axillary, supraclavicular, and internal mammary regional lymph node is challenging. A meta-analysis of MA20 and UATC suggested that the addition of nodal irradiation to the level 3 axillary, supraclavicular, and upper internal mammary lymph nodes conferred an improvement of disease-free survival and the distant metastasis-free survival, as well as 1 to 2% overall survival advantage. Results of a sub-analysis from the ALTO trial, there was no DFS benefit of nodal irradiation in the HER2-positive, node-positive patients treated with adjuvant HER2-targeted therapy. The potential benefit of nodal irradiation might depend on the extent of axillary lymph node dissection achieved and the adjuvant chemotherapy. The individual decision on nodal irradiation should be based on the risk factor and the required application of modern radiotherapy technique with heart sparing. Because of the toxicity, though there is evidence and there is a mention of comprehensive nodal irradiation in the NCCN guideline also, but in practice, very rarely we do the comprehensive nodal irradiation. We generally cover the medial supraclavicular lymph node and level 1 and 2 axillary lymph node only. Next slide. Thank you. Next.
Okay, thank you, Dr. Nayan, for your comprehensive presentation.
Thank you,
and
sir.
There is already a question on the chat box. And any other questions, I think you can put it on the chat box so the speaker can answer that.
Yes, sir.
Dr. Vikas, what about the next topic? Dr. Syam is not here, I think, with us.
No, Dr. Syam.
Shall we proceed? Shall we proceed to the next?
Yeah, you can proceed, sir. No problem.
Okay, our next topic is on the chemotherapy decision making in early breast cancer. May I invite Dr. Naresh Jagtap, who is a consultant medical oncologist from Narayana Super Specialty Hospital, for his presentation.
Yeah, thank you, sir. Am I audible?
Yes.
Yeah. Good evening to all the respected members. First of all, I'd like to thank the Association of Oncologists Northeast India for having me for this deliberation. Today, I'll be discussing the role of chemotherapy and chemotherapy decision making in early breast cancer. So basically, I'll be going through the various dilemmas that we face in day-to-day practice in terms of decision making, and we'll also see the evidence that supports that. Next slide, please. So as we know, as per the latest Globocan data, that breast cancer is the most cancer common globally, including both the sexes, and obviously it is the most common malignancy amongst Indian females. Unfortunately, due to poor screening behavior, almost 70% of the cases are diagnosed at a locally advanced or metastatic stage in India. Next slide, please. Next slide, please. So what do we exactly mean by early breast cancer? Let's start with the basics. Now, there is no universal definition as such. Different groups tend to have different kinds of inclusion criteria. But by and large, stage 1 and stage 2 are definitely included in early breast malignancies. In some of the studies, operable stage 3 breast cancers are also included in early breast cancer. There is a school of thought where some believe that stage 2B should also be considered as locally advanced, but by and large, stage 1, stage 2, and in some studies, operable stage 3A is included in early breast cancer. Next slide, please. So when we say the role of chemotherapy in early breast cancer, broadly you can categorize it as neoadjuvant and adjuvant. In neoadjuvant, the role of chemotherapy in EBC is restricted to reduction of tumor size in order to achieve breast conservation. And that's a no-brainer whether we have to give chemotherapy or not, because here the purpose of chemotherapy is to reduce the tumor size. Whereas adjuvant, we all know its aim is to kill the microscopic residue and improve relapse rates and survival. Next slide, please. So basically, the dilemma comes in case of adjuvant chemotherapy. So what are the questions that we commonly come across? Number one, whether we actually need to offer chemotherapy to these patients or not. If we do offer yes, Then what regimens do we give and for how long? What are the absolute benefit of chemotherapy in a given particular patient vis-a-vis the long-term toxicity? And then comes the rare and uncommon scenarios. Next slide. Now, to give or not to give, the core to this answer lies in the ability to predict the possibility of relapse in your given patient. Now, there are several parameters on which the prediction of relapse can be done, of which important are clinical features, of which the most important is absolutely the stage, the age of diagnosis, the pathological features like the grade of the malignancy, adverse pathological features like lymphovascular invasion, perineural invasion, most importantly, the molecular subtype in which we have the luminal A, luminal B, which basically indicates whether it's a hormone positive, HER2 positive, or a triple negative disease. Of late, genomic expression profiles have come up as a new tool in order to predict the behavior of the disease or the possibility of relapse. And we also have certain online tools which help to predict the possibility of relapse. So these are the tools that help us to predict the possibility of relapse. Mind you, most of these are prognostic markers, not predictive of benefit of chemotherapy, but they do give us an idea about the possibility of relapse, and then we can follow the simple thumb rule that higher the possibility of relapse is, the more the benefit with adjuvant chemotherapy. Next slide. Next slide. Yeah, so this is a extract from the St. Gallen's 2007 meeting, where basically they have used the clinical criteria, the pathological criteria, and the expression status in order to categorize breast cancer, early breast cancer into low risk, intermediate risk, and high risk. So this classification is more of a prognostic importance, but it doesn't give us a comprehensive idea about the predictive benefit of adjuvant chemotherapy. Next slide. Yeah. So when we talk about chemotherapy regimens in early breast cancer, there are n number of regimens. But if you broadly classify these regimens, you can somehow categorize it into these broad four headings. Number one is the sequential and the combination regimen, in which anthracyclines are followed by taxanes, which is popularly called as the third generation evolutionary chemotherapy in breast cancer. Then we have the anthracycline based chemotherapy regimens, which were one generation older than the sequential or the combination regimen. Then of late, due to the long-term toxicity of anthracyclines, we have non-anthracycline based combinations, of which TC is one of the most commonly used regimen. And then we have the HER2 new based regimens, in which you can use either a single agent or a combination of HER2 new agents. Next slide, please. So I'll be discussing this decision-making chemotherapy in early breast cancer in terms of the receptor status. First, I'll be discussing whatever the guidelines recommend. Then we'll see the evidence for those on which those guidelines are based. And then we'll go through a set of my personal choice, which I routinely use or prefer to use in my clinical practice. So in case of triple negative early breast cancer, now let me make it very clear. Whenever I say node positive, it is always less than or equal to 3 nodes, because we are talking about early breast cancer. So in a triple negative breast cancer, if it is node positive, it's a no-brainer. You have to give chemotherapy. Adjuvant chemotherapy is warranted. If it's a node negative disease and the size of the lesion or the size of the primary is more than 5 mm, yes, chemotherapy has shown to improve outcomes. But when the size of the tumor is less than 5 mm, guidelines generally say that chemotherapy might be skipped. However, this comes with a rider in which they say you tend to assess or consider other parameters like age of the patient, the menopausal state of the patient. So generally, if somebody is a T1A and who is node negative and 35-year-old, it can still be considered for adjuvant chemotherapy. Next slide. So coming to the data in breast cancer, now this is, we are all probably familiar with the role of taxanes in breast cancer. It is very well established. I'm just presenting to you a meta-analysis which included all the taxane-based trials, and what they found was that taxanes cause survival benefit in node-positive breast cancer. In node-negative breast cancer, there is conflicting data about the advantage added on by taxanes, but there are ample evidence to suggest that node-negative high-risk patients in which the primary tumor is bigger, it's a high-grade disease, taxanes do add on to survival. Next slide, please. Next slide. Next slide, please. Go one slide back, please. One slide back. Yeah. So this is another important article published way back in 2006 in JCO, where basically they compared an non-anthracycline based regimen compared to an anthracycline based regimen. Now, basically, we don't have many trials comparing one regime to another. So this is one of the few trials which actually gives us an idea about the superiority of one regime over the other. So this is early breast cancer patients, which included stage 3 operable patients, and they were randomized to 4 cycles of AC versus 4 cycles of PC. 30% of these patients were TNBC. I'm stressing on this number because currently we are discussing TNBC, and it was shown that the DFS rate was superior for TC, which is a non-anthracycline based regimen, versus 4 cycles of AC. Next slide. So considering all this data, what is my common approach in my clinical practice? In a node positive early breast cancer, which is TNBC, I would give a sequential regimen. One, because node positive warrants chemotherapy, and sequential regimens have shown to have survival advantage over conventional anthracycline based regimens. In node negative high risk patients, I would give chemotherapy, and I would again go for a sequential taxane based regimen. Here, my alternative option would be a pure taxane based regimen if a patient has cardiac comorbidities or wants to avoid the long term toxicity. In a node negative low risk patient, I would be tempted to avoid an anthracycline, and I would go with a pure taxane based regimen. As I discussed in the previous JCO study, I would like to go with the TC. Or if I have to, if by some reason patient is not eligible for TC, I would go with a pure anthracycline based regimen. I would not use a sequential regimen if the patient is node negative, low risk. So these are just the preferential regimens that I would say. Next slide, please. So coming to HER2 positive early breast cancer. So again, in HER2 positive early breast cancer, node positivity, again, no brainer. I would use chemotherapy in these patients in combination with a HER2 agent. In node negative, if the size of the tumor is more than 1 centimeter, it's a no-brainer. You have to use chemotherapy because this subset of patients have shown to benefit. The problem comes when the size of the tumor is less than 1 centimeter. I've written here since smaller because it has a rider that the behavior of HER2 positive tumors which are less than 1 centimeter is highly unpredictable. The importance of HER2 overexpression in these small tumors is debatable. More so in HER2 positive and hormone, you do give chemotherapy, but that recommendation is of a lower grade of category 2B. Next slide, please. So HER2 versus non-HER2. Next slide, please. Again, no brainer here. In a HER2 positive malignancy, addition of an anti-HER2 agent has shown survival benefit. We all know it. It's not a point of contention. But the reason that I have brought in this BCRG trial here is that what we need to understand that in this trial, almost 30% of the patients were node negative, and 40% of the patients had a tumor size of less than or equal to 2 centimeters. And this trial had an overall positive outcome in the intention to treat population. So that just gives us a hint of an idea that HER2 positive or HER2 based therapy is equally effective even in smaller tumors, though these patients were heavily underrepresented in most of the trials. Also, this trial gives us a HER2 based non-anthracycline based chemotherapy backbone. Next slide. dual versus single, whether we give a combination of trastuzumab with HER2 or as a single agent. So the data here comes from the affinity trial. So we need to understand the trial basically was designed with HER2 positive breast cancer patients, and there was randomization between chemotherapy plus trastuzumab and chemotherapy plus trastuzumab plus HER2. Important point to note here is that 63% of the patients in this trial had a nodal positive disease. Next slide. If we see the results, overall in the intention to treat population, though the affinity trial was positive, the quantum of benefit was very low, and you can see the hazard ratio reached almost 0.8. So the quantum of benefit is extremely low, and that you have to consider when you're adding an additional drug in adjuvant therapy which has got toxicity. In node negative patients, there was no benefit in terms of invasive disease-free survival by the addition of pertuzumab. However, in patients with node positive disease, there was a statistically significant and you would say a clinically meaningful benefit by the addition of pertuzumab. Next slide. Trastuzumab in T1 lesion. I just came across this meta-analysis which is very interesting, which gives us an idea about to the question whether anti-HER2 therapy is effective or has a quantifiable benefit in extremely small lesions. So this is a meta-analysis which has published. DFS and OS were its endpoints. They did separate analysis for node positive and node negative patients, and the median follow-up was 8 years. Next slide, please. Now, if you see the result of this study, they have categorized HER2 positive tumors, which are T1 lesions, that is less than 2 centimeters, as hormone positive and hormone negative. Irrespective of the hormone status, the DFS events and the overall survival events were less in the trastuzumab arm, which translates into the fact that patients who receive trastuzumab tend to live longer. And if we can see the comparison between the two arms, the DFS and the OS events in the hormone receptor positive arms were again lower compared to hormone receptor negative arms, which probably could be attributed to the fact that hormone receptor positive tumors tend to behave better. So the quantum of benefit would be slightly less in the hormone positive T1 arm. And this is exactly what they have concluded, that patients with HER2 positive with tumor size of less than 2 centimeter derive substantial DFS and OS from adjuvant trastuzumab, but patients who are hormone positive and with a lesion of less than 2 centimeter, you might consider for de-escalation of the therapy. Next slide, please. So, if a HER2 positive early breast cancer patient comes, if the patient is node positive HER2, obviously we have to give a trastuzumab based regimen. There is apparently no difference between the different regimens. The study BCRG showed that TCH is slightly better, but for all practical purposes, different regimens are more or less the same. Now, this is only one category of patients where I would consider adding pertuzumab to the patient when the patient is node positive with a good nodal burden and a large tumor size, for the simple reason that majority of the patients in the affinity trial were node positive. A substantial, statistically significant and quantifiable benefit was seen in node positive individuals only. And I believe that this is the only category of patients which justifies addition of another toxic therapy and the financial burden for the minimum quantum of benefit that we get out of pertuzumab. In node negative patients who are more than 1 centimeter, I would use the traditional trastuzumab based regimens. If the lesion is less than 1 centimeter, I would go and give a trastuzumab based chemotherapy regimen based on the meta-analysis that I discussed previously. If it's a hormone negative tumor, I would go with the full-blown regimen of AC followed by T plus trastuzumab or TCS. If it's a hormone positive tumor and it's a tumor that is less than 1 centimeter, I would probably consider skipping anthracyclines in this, and I would probably give a paclitaxel with trastuzumab followed by trastuzumab maintenance, because the overall benefit in hormone positive patients with tumor less than 1 centimeter is still debatable. Next slide, please.
Dr. Naresh, you are
Now coming to the last part of my discussion in hormone positive early breast cancer. This is probably one of the more controversial areas. If it's a node positive disease, again, there is a rider here. Many would end up actually giving chemotherapy, but in case of early breast cancer that are node positive, they say you assess the clinical as well as the pathological factors which predict the risk of relapse, and you take the help of genetic expression profiles. We'll come back to that later. In node negative, if it's a T1A lesion, there is no benefit of adding chemotherapy. That has been shown by a number of trials. And if it's a T1B, C, or T2 lesion, you go for gene expression profile analysis. Next slide. So if gene expression profile, if the risk score is low, you don't give chemo. If it is high, you give chemo. If it is not available or not affordable, you give chemotherapy. If it is intermediate, again, the reason yes, no is the recent update by the Taylor-H trial says that these patients don't benefit with the addition of chemotherapy, but there is a rider that a subcategory of these patients with a recurrence score of more than 100 or high grade, you can still consider chemotherapy. The Oncotype DX in node positive patients, the RX Founder trial published its results in December 2021, and the overall trial concluded that in intermediate, in patients who are node positive with a recurrence score of less than 25, postmenopausal females can avoid chemotherapy. Next slide, please. When we use MammaPrint, now we need to understand. Yeah.
Can you conclude
Hello?
fast? Because you
Yeah. Next slide, please. Can we go to the next slide? Next slide. Can we go to the last slide, please? Last where we have discussed the different regimens in breast cancer patients. Next slide, please. Next slide. Yeah. So in hormone positive breast cancer patients, node positive patients, if I have to eliminate chemotherapy, I would mandatorily do a MammaPrint for these patients or an Oncotype DX. Oncotype DX, I would be slightly skeptical because the data is relatively new. If I have to give chemotherapy for node positive, I would definitely add a taxane. In node negative high risk patients who are hormone positive, I would still go ahead and add a taxane. And in node negative low risk patients, if at all I have to go for a chemotherapy regimen, I would use an anthracycline free regimen. Next slide. So the key takeaways here is most of the triple negative and HER2 positive early breast cancer patients will require chemotherapy. Taxanes have shown survival benefit in node positive and high risk node negative EBC patients. Some of the hormone receptor positive EBC patients do well without chemotherapy, subject to the fact they are selected properly based on clinical, pathological, and genomic criteria. Next slide. Thank you. Thank you so much. Sorry for overshooting of allocated time.
Yeah, I have a question. Yeah, Dr. Naresh.
Yes.
So in a scenario like a post-mastectomy case, so on medical oncology evaluation, they have found a metastasis in the liver. They have planned for palliative chemotherapy, taxane for 8 cycles. Okay, taxanes for 8 cycles. So on review, a surgical oncologist sees the cases and he sees it's a small lesion, liver lesion. So he goes for metastectomy. As the patient is a young patient, 42 years, so he has done metastectomy. Now, should this patient be involved for anthracycline-based chemotherapy or seconamide? It is a positive, hormone positive, HER negative, and Ki67 is 20%.
Hormone positive. Hormone positive.
Yeah, hormone positive.
And HER2 negative.
HER2 negative.
post-surgery liver was the only site of metastasis?
Yes, liver is the only site of metastasis.
So, yeah, so in this scenario, sir, I would have considered giving a full-blown regimen of chemotherapy, that is anthracycline followed by taxane after the surgery itself, because this would come in the purview of a oligometastatic disease. So the intent in this patient would still be curative. I would give the full-blown chemotherapy upfront because it will help me in two ways. One, it will tell me the behavior of the disease, the biology of the disease, and it will also tell me how the disease is responding to my chemotherapy. If the disease progresses during the chemotherapy, it would anyways avoid a futile hepatectomy in the future.
No, my question is, I have already done hepatectomy to this patient. We have the posterior sectionectomy to this patient. Now the patient, now I have to start. This is the question. The patient is waiting. Is admitted. So I am planning for anthracycline base and to omit taxane because he have already received 8 cycle of taxanes.
Yeah, giving anthracycline, I mean, obviously we will not have any data regarding such kind of scenario. But yes, in such a case, if the patient is 41, I would still go ahead with giving 4 cycles of anthracycline to this patient, followed by endocrine therapy. I would treat it as an adjuvant case.
Adjuvant. So
the only thing is the adjuvant chemotherapy we have given kind of as a perioperative therapy.
Exactly. So I can omit taxane, you mean to say, right?
Yeah, since she has already received taxanes previously, she would not. I mean, 8 cycles of taxanes is still a fairly good number of good dose of taxanes. I would go with 4 cycles of AC followed by hormonal therapy.
Okay. Thank you so much. Thank you so much.
So do we have any more questions or Dr. Jagtap?
Yes, sir. We can conclude the session, sir. Thank you.
Yeah, I think we'll conclude. And it was a nice session. And of course, there are a few questions that came to my mind, which actually encompasses across both the surgical Dr. Purohit and Dr. Naveen who presented. There's one question I just like to ask. You, Dr. Purohit, if you do lymph node biopsy, irrespective whether the central lymph node biopsy came positive, one node came positive, and you go ahead and do a lymphadenectomy. Because in any case, as Dr. Naveen said, after patients come to him for radiotherapy, apart from the breast field, they're also including minimum level 1 and 2 of the lymph nodes in the axilla, and including level 3 and supraclavicular areas. So in effect, both areas are being treated once sentinel lymph node biopsy is positive by radiotherapy. Now the question is, this question is to both of you. The complications of the axilla, treatment into the axilla, if I were to use surgery or radiotherapy, how is it different?
Sir, if after the surgery, if you add the radiotherapy, definitely there is a more chance of...
Only surgery, because if I have completed the axilla part, then probably I wouldn't be going for radiotherapy.
Yes, sir.
Yeah. So
yes, sir. In clinical practice, we do not. Actually, I highlighted the evidence and the guidelines, but in clinical practice, we do not cover the axilla, especially level 3 after the axillary lymph node dissection.
I just wanted to know, what are the difference as far as the complications of surgery and RT to the axilla is concerned?
So basically the
complications.
Basically the lymphedema, the chance of lymphedema will be more if you irradiate higher axilla.
True. Now, because the moot point there remains, you treat the axilla, you have two options, either treat by radiotherapy, which in any case we are doing in most of the cases where it is sentinel lymph node biopsy positive.
Yes, sir.
Other option is, at surgery itself, you could have gone and treated level 1 and 2 minimum, because level 3, of course, there's a lot of talk whether we should go be above the axillary vein or not, because that increases the chances of lymphadenopathy, the lymphedema much more. So usually level 1 and 2 is something that we always clear. And mind you, when we do surgery where the axilla is not loaded with lymph nodes, the chances of having surgical complications in the axilla is much, much less. That's just a thought, I think a thought-provoking question, may not be really something that we need to answer here. I think this is a thought that we can all carry home. Thank you.
Thank you, sir.
Over to you, Dr. Jagtap.
Yeah, Thank you, sir. And I thank all the chairpersons, Dr. Topno sir and Dr. Zotan Kima, and all the speakers, Dr. Pulomi, Dr. Naveen, and Dr. Naresh for the wonderful session. Thank you so much. So we'll move on to our next session. So next session is a panel discussion on rectal cancer. For that, I would like to invite Dr. Gaurav Das.
Yeah.
Gaurav Das is the. In the meantime, Gaurav, you can start sharing your screen and introduce other people.
Am I audible?
Yeah, you are audible. So, Dr. Gaurav Das is an associate professor in the Department of Surgical Oncology at B. Purohit Cancer Institute, Guwahati. Gaurav, you can share your screen in between.
Yeah, I am doing that.
And for the panelist, I would like to invite Dr. Anupam Mahanta is not able to join us. So I will request Dr. Kunjahari Mehdi. He is the consultant medical oncologist at Batra Hospital, New Delhi. Dr. Aftab Ali Ahmed. Dr. Aftab is the assistant professor in Department of Surgical Oncology at Jorhat Medical College. Dr. Ashish Kumar Gupta, he is associate professor surgical oncology of Atal Bihari Vajpayee Regional Cancer Center, Agartala, Tripura. Dr. Jyotiman Nath, who is assistant professor of radiation oncology at B. Purohit Cancer Institute, Guwahati. Dr. Yukerin Khongla, she is the associate professor in the Department of Pathology at Nigrin, Shillong. Dr. Palash Jyoti Das, who is a consultant oncoradiologist at Guwahati. Dr. Sandeep Taparia, our favorite nuclear medicine specialist from Guwahati. And Dr. Rubu Sunku, she is a consultant radiation oncologist at TRIMS Naharlagun, Arunachal Pradesh. So I welcome you all. I think Gaurav has already shared the slides and the points in the morning with you all. So I hand over to Gaurav to start the session. Thank you. I think all the panelists can unmute themselves so that they can contribute to the lively session. Thank you.
Thank you, Vikas, sir. I hope I'm still audible.
Yes, you are audible.
And I hope my slides are moving. Because
sure.
Yeah. At the very outset, I would like to thank the organizers of this beautiful conference. And I also thank you, Vikas, sir, especially for making my job a little bit easier by introducing my panelists. So we begin right away. Our panel discussion is on rectal cancer. I've kept it very simple. I'll be discussing only one case and some what-if scenarios related to that case. So our patient is a 49-year-old gentleman. This is a real case which we dealt with quite recently. Presented with bleeding for rectum for 3 months, and he doesn't have any comorbid conditions. On examination, he was in good performance status, only had pallor. And per abdomen, there was nothing significant, no significant inguinal nodes. On parectal examination, we found a growth which was starting from 5 centimeters above the anal verge and located between 2 to 12 o'clock positions in a clockwise direction. One finger was admitted without any difficulty, and of course, the sphincter tone was normal. We come directly to the surgeon because he is the first person who would be dealing with such cases. Like question is to Dr. Ashish Gupta, like how will you proceed? Like what investigations would you ask?
Good evening, everybody. And I want to thank the organizers for inviting me to the CME as a panelist. And actually, my first assessment will be I would like to do a digital rectal examination. And I would like to look for the clinical assessment. I would like to see for the distance from the anal verge and mobility of the tumor, whether it is fixed to adjacent structures, tenderness, the extent of circumferential involvement, and maybe any bleeding and all those things. And after that, I will also like to get a contrast enhanced CT scan of the chest and abdomen to rule out any distant metastasis and for local staging. I will also like to get a MRI of the pelvis for local staging of the disease. And I would like to get a colonoscopy for any synchronous lesions in the colon. And I would like to get a CEA for the burden of the disease and basic workup for general condition and nutrition status assessment of the patient.
Okay, that's rightly pointed out, and almost comprehensively you've included almost everything. So we do the CBC, CEA, colonoscopy, biopsy for local staging, pelvic MRI. For metastatic workup, we choose CT scans. Young patient, we may be concerned about fertility counseling and all. We come to this controversial topic, PET CT scan. Like I would like to bring the nuclear medicine person here, Dr. Sandeep. Could you please tell us like how relevant is PET CT in rectal cancer and when should we at all use it?
Yeah, good evening, everyone. Am I audible?
Yes, yes.
Yeah, see, in this NCCN guidelines has clearly mentioned that there is no role of PET CT scan in upfront staging. But these guidelines are made in US. So like US people do PET CT without contrast. We in India, most of the centers are doing PET CT with oral and IV contrast, means a diagnostic quality CT. So by suppose some unknown patient presented with unknown primary and we have done a PET CT. So in those cases, I do not, personally, I do not endorse doing PET CT upfront or for staging in carcinoma rectum. But like suppose for some other reason patient has already gone PET CT, so you don't have to go for contrast CT again. That is a point I want to make clear. First thing, and in upfront staging, initial staging, there are few indications, like suppose there is some equivocal finding on CT scan, or suppose the patient is having CRF or contrast to allergy. In this, like patient could not be used IV contrast. So in those scenarios, we can go for PET CT scan upfront. And suppose patient has M1 disease, like oligometastatic M1 disease, and you want to see whether there is metastasis to anywhere else in the body, so that you can take a curative approach, curative surgical approach. So in those cases also PET CT is indicated.
Okay, we'll keep those things in mind. At this point, I would like to give some additional information. Like we did all those investigations, found that hemoglobin was 8. Other blood investigations were normal. CA was 6. Colonoscopy growth was from 5 to 10 centimeters. Rest of the colon was normal. Biopsy was adenocarcinoma grade 2. And I have already shared the MRI images with our radiologist, Dr. Palas Das. He will guide us through the imaging slides. Dr. Palas Das, please.
Yeah.
Yeah, I'll go to the very first
Good
one.
evening, everybody. Am I audible?
Yes,
Hello.
Palash, you are audible.
Gaurav, am I audible?
Yes,
Yes,
you are audible.
yes, Palas,
Yeah,
you're audible. Very much.
Yeah. Thank you, Vikas and the team, for including me as panelist in the team. So this is a good quality MRI I have seen done for the patient. So this is a situated fat suppressed sequence of the patient. So first of all, what we have to look for the MRI of a patient with colorectal cancer. First, we have to describe the type of tumor, whether it's solid or mucinous, because mucinous has a poor prognosis than a solid tumors. Then the location, then the length of the tumor, whether it's involving distal, upper or mid rectum, and its relation with the anal verge. So in the sagittal image, you can see that tumor is above the anal verge, and it's not up to the mark of the peritoneal reflection, because so that's why it is in the lower rectum. So in additional, you can see some multiple prominent nodes in the mesorectum. This is also in the superior mesorectum. So I would like to see the axial images to comment on the mesorectal fascia. Yeah, this is the axial image showing the almost semicircular to circular pattern of involvement of the disease of the lower rectum. So predominant bulk of the growth is seen in the right lateral aspect. You can see there is full thickness involvement of the rectal one and right lateral aspect, and in the lower images you can see there is a breach in the hypointense muscularis propria of the rectal wall. So there is extension outside the muscularis propria with involvement of the mesorectal fat. So depth of involvement of the mesorectal fat should be around 1 to 5 millimeter. So disease will be a T3 A or B, in between A and B. So local staging will be T3A or B. So already I have mentioned we have seen multiple prominent lymph nodes in the mesorectum. It's predominantly seen in the right lateral aspect, which is also going into the superior mesorectum. And there is a suspicious node in the right internal iliac station. So it's a lateral node. It looks suspicious, although the scale is not applied to the image. It looks suspicious.
Okay. So we have a local staging. It is a mid-rectal tumor, probably going a little bit to the lower rectum as well. T3B and 2, as there were like 7 significant nodes that were counted by the radiologist in the console. EMY negative and mesorectal fascia was free. And we did the metastatic workup. We selected CT scan, thorax, and upper abdomen. It was a non-metastatic disease. And so we have a final clinical diagnosis, which is adenocarcinoma grade 2 of the mid-rectum, T3B and 2M0, MRF-free, clinical stage group 3B. We bring the case to the Joint Tumor Board as is expected for oncological cases. At this point of time, I will just seek permission from my panelists to give me 2 minutes time to go for a brief monologue, like how, what, and why to choose. So like the standard of care has been all throughout, like for locally advanced colorectal rectal cancer, to give neoadjuvant chemoradiation, then operate with a good quality TMA, and then give adjuvant chemotherapy, or give short course radiation and do delayed surgery and adjuvant. Then came neoadjuvant, total neoadjuvant treatment, where short course or long course chemoradiation was combined with neoadjuvant chemotherapy in the preoperative setting, and then surgery was done. In NCCN, like for this subset of tumors where the mesorectal fascia is free, they have included these options. Whether if it is T4 or MRF positive disease, they have actually excluded the traditional approach and thus given the option of total neoadjuvant treatment. There is nothing else. So TNT is probably the way to go in locally advanced rectal cancer, debatable, but then probably that is what is emerging from all the evidences, meta-analysis, which show that PCR rates are better, disease-free survival better, and that has invited commentary like compliance is better in the neoadjuvant setting. And similar meta-analysis have shown that odds of PCR more by 39%, and DFS as well as distant metastasis risk is much less. 2021 saw the results of Rapido with short course radiation with neoadjuvant chemotherapy providing significantly improved PCR, and failure rates are much lesser, as also for the long course chemoradiation with chemotherapy, similar results, better. So we come back to the panel, like increase PCR, increase DFS, decreases distant failure. Like what should we select? We hope this will keep the discussion alive. As Dr. Anupam Mahanta sir is not there, we would like to ask the medical oncologist like how to sequence, how to go about it, and why we should do that. The medical oncologist, Kunjahari sir, are you online?
Wow.
Yes, sir. We wanted your opinion regarding sequencing of TNT.
Bhuyan sir is there or Umesh Das is there? Anyone can take
Any other medical oncologist online, kindly come to a rescue. Like,
Okay, fine. If there is no one else, then I stand
yes, sir.
here. Gaurav?
Yes, sir. Yes, sir. Great to have you, sir.
You have nicely put the recent things up, okay, already. The options are we can go ahead with neoadjuvant chemoradiation or take to neoadjuvant chemotherapy. Surgery remains, surgery has to be done, right? Now, the standard treatment practice has been chemoradiation for a long time. Now the results of neoadjuvant chemotherapy alone are coming up as well, challenging each other.
Yes,
so it's very difficult at this moment to pinpoint, because this is not yet no head-to-head comparisons between these two. But then I think, if you ask me, then I'll prefer chemoradiation, neoadjuvant chemoradiation, provided the chemotherapy specialists, when medical oncologists, surgical oncologists, and radiation oncologists are in tandem discussing together. But in other situations where this facility is not available, still the patient's treatment has to go ahead. The patient is in a hand of a medical oncologist, and the surgeon has referred to him. Then probably we finish the neoadjuvant chemotherapy and send him back for surgery and then subsequent treatment.
Okay, just one more to add to that. Like in the TNT
Yes.
approach, would you prefer to give chemotherapy followed by soft course RT or chemoradiation, then surgery, or like that is induction or consolidation, like chemoradiation followed by chemotherapy and then surgery? Which one is your preferred
I
approach?
think I think if we do chemotherapy, we'll do chemotherapy and then send for surgery. And then
Yes,
analyze
sir.
after surgical report. Anybody else putting in some information?
Yeah, like what Gaurav is asking is, sir, like whether you will do like consolidation of surgery, or that whether you will choose. There are two trials going on, Rapido and Prodigy.
Yeah.
So which of the trials you will choose?
Yeah.
That's what
No,
he's asking.
you can give it, because I'm not very no, I have proxied only suddenly, and then I'm not thorough with that trial. So you can give us the input after.
Okay, sure, sir. Thank
If
you.
you
so
have
much,
the
sir.
results, you can put up. Yeah.
Sure.
Or Gaurav, you can put. Yeah.
Yes.
Result.
The results of the trial, like yeah, this was the short course short course chemotherapy followed by short course radiotherapy and then chemoradiotherapy versus the traditional approach. And what they found here is the PCR rates were much better when they compared the experimental arm, that was 27.7% versus the traditional thing, that was statistically significant. And also because chemotherapy was given in the preoperative setting, the micrometastasis probably was dealt with earlier. So distant metastasis was found to be significantly less, and the locoregional failure also was less. And similar results were found when the neoadjuvant chemotherapy was added to long course chemoradiation in the preoperative setting. So surgery was done last in the sequence of things in both of these trials.
Yeah.
So this was in 2021.
Okay.
So is that a way to go for all locally advanced rectal cancers, or we just reserve it for a subset like T4 and MRF positive disease like NCCN says? That was the debate.
Right.
Okay, we come to our radiation oncologist, like what he feels like, what is his input to this short course RT or long course chemoradiation, and why? Dr. Jyotiman, please.
Am I audible?
Yes, yes.
Yes, yes.
Yeah, thank you, Gaurav. So as this controversies regarding which one is better, short course radiotherapy or long course radiotherapy. So the first trial who's demonstrated which compared short course radiotherapy with a long course treatment was the POLIS trial. So obviously they have found that long course radiotherapy found a better pathological complete response, but other oncological outcomes like disease-free survival, overall survival, both are comparable. So other few more randomized trials also done, some meta-analysis also done. So every these trials they presented a comparative prognostic results for both the strategies with a equivalent overall survival and local regional control. So based on whatever available evidence we have, it can be concluded that this short course radiotherapy and long course radiotherapy, these are actually not competing to each other. They are complementary to each other in different clinical scenarios. So as mentioned in different clinical scenario guidelines, the long course radiotherapy is preferable for those particular patients with distally located tumors, more advanced T3, T4 tumors with positive clinical CRM positive tumors, positive lymph nodes, where additional downstaging is required by the surgeon, which will be helpful for getting a PCR. Whereas in a short course radiotherapy appears to be a safe alternative actually for those patients which are small, relatively proximal tumors. So for in this particular patient, since it is a nodal positive patients, so definitely a long course chemoradiation in the line of the PODIS 23 trial would be preferable, I must say.
Okay, let us get the opinion of another radiation oncologist in the panel, Dr. Rubu Sonku. Do you agree with Dr. Jyotiman, or you have any contrasting view? Dr. Rubu, please.
Good evening, everyone. So, in this case, I think short course and long course, I think what will be applicable. Actually, my daughter is disturbing. So, but it depends on the comfort of surgeon as well as radiation oncologist, whether short course can be considered in this or not. Because again, the difference in the short course is because the toxicity is much lesser. And usually patients complete it very well. Their compliance is better. But the pull-off surgery is necessary. It should be done timely. While in case of long course radiation, the toxicity is higher, but time we can give certain amount of time before surgery. So I think both are comparable and can be considered based on the comfortability of surgery.
Okay, thank you. So Dr. Rubu feels that the compliance is better with short course because it's finished in 5 days and the long course takes much longer. And the other thing is the Rapido trial also included T4 disease and high nodal burden. So probably those short course and long course chemoradiation are equivalent as far as downstaging is concerned. But then organ preservation rates, as we'll come back later in the discussion, is better with chemoradiation. A little while ago, like a decade ago, the things were a little bit different. And whether we should at all go back in time machine and see all those things is debatable. But for the fact of relevance, because many things are still being practiced, we'll go back to that. ESMO guidelines in 2017 had a risk-based approach, and there was still a role of doing upfront surgery in some certain subsets of disease, like early or intermediate type, where the good and the intermediate bad groups like T3A or T3B disease located in the upper and mid rectum underwent upfront surgery with a good quality TME. But NCCN has removed all those things. They have said some sort of neoadjuvant treatment is needed, and upfront surgery is probably not the way to go in today's date. Come back to the surgeon because he's the central person in the scheme of things to offer a curative option. Like when would he time his surgery? Dr. Ashish Gupta, please.
Actually, ideal time for surgery, I feel, will be at probably 6 to 8 weeks. I will say 8 weeks exactly. So at our center, we usually start evaluating, because it's a government institute, so we start evaluating the patient somewhere around 6 weeks. So we get the patient around 8 weeks. But I have operated patients, some patients who are at 4 or 5 months also post completion of CTRT. And my experience is that even those patients, we have not found any gross difficulties. I mean, the surgery has been okay. We didn't find any gross adhesions which could have caused a lot of problems to us in TROP. But still, I will maintain that ideal time for operation surgery will be somewhere around 2 months.
Okay. Because there is a trial, Greco 6 trial, which showed that if the surgery is delayed by more than 11 weeks, the quality of TME was worse because of the fibrosis. And in fact, in the Corona times, we also had a lot of patients who came much beyond the time period, and we had to operate. Sometimes it becomes difficult. Surgical questions again to Dr. Ashish Gupta and Dr. Aftab. Does neoadjuvant treatment improve the sphincter preservation rates? If it is a low rectal tumor, do we get away with a sphincter preservation surgery with neoadjuvant treatment?
Neoadjuvant chemoradiation.
Okay.
After
So, like, what is
like to take it?
Yeah, like the basic idea, like if you see the evolutions of the pre-operative or perioperative management has been to for the sphincter saving. That was basically the urge of the surgeons to functionality of the patients. So in this regard, the neoadjuvant CTRT has really proven to improve the sphincter saving surgeries. So and with the new these Prodigy and this Rapido trials with phase 3 trials, so now it has also proven neither is only prison saving, it's also organ saving in advanced cases. It shows a lesser number of organ sacrificing. So this neoadjuvant setting has really improved the surgical outcomes, and whether so it is besides the local control, good control is also giving good control in the distant systemic metastasis also. So these all results are showing these are very positive trials. We hardly get a lot of positive trials now, but these two trials have really changed us, keeping hope for more. Like so So, but there is still a lot of pitfalls in these trials, which are discussed, and some understanding or conceptual understanding is needed for that. And there is some reviews by Gutano, by institute from Italy. They have reviewed it so very well, and they have categorized these stage 2, stage 3 cases, like they are basically for which this neoadjuvant setting has is done or put on. So in this setting, they have reviewed from historical aspect of the TNT regime, historical aspect of how it have evolved. Basically, it has evolved during when we have historically, if you see when the neoadjuvant RT was started, the recurrence rate has come in from 70% to 30% or something like that. Forgot the figures, but it has drastically come down to. So that's how it was incorporated. Now the time between the radiotherapy and the time of surgery, there is the time needed for the radiotherapy to work on the tissues. So that time was needed 3-4 weeks, though that time was found, and subsequently the incorporation of systemic therapy has come into play. Then they have got to intensifying this systemic therapy basically, and now the intensification is on the peak, like basically triplet. They are going on triplet drugs, so now whether to choose this triplet regimen or not, or to go for because between these two regimes, I think so Proteso and Rapido, we have to choose very carefully of the patients. So the questions regarding whether it has improved the spincher saving, yes, it's totally helped to spincher saving, and its spincher saving rates are high. Sorry, I have been quite long.
That's okay. Yes, very rightly pointed out by Jagtap, sir, that we have evidences of sphincter preservation rates being improved after chemo radiation, and that we came to know almost more than a decade earlier from the German trial itself. But then after short course RT, whether actually sphincter preservations are higher, that needs to be seen. Evidences will definitely come up. After the would you choose open or minimal invasive? Are they equivalent?
Personally speaking, I don't have much experience in minimal invasive. I had the chance to work with Dr. Sakti Sahu in Bhubaneswar, but I found it quite interesting, quite easy, and saving of time. Lots of advantages are there. But personally, I have not got a chance. But I prefer for open. I feel much more comfortable in open. Though minimal invasive, much more. I think so. It's quite safer. Colorectal, it is proven great result.
Dr. Ashish?
As long as we can do our surgery with clear TME and taking adequate margins, I think it should be because it depends on the skill of the surgeon. If a surgeon is adequately skilled to perform a laparoscopic surgery and taking the same adequate margin, then probably it can be preferred. Reason being, the earlier trials which were done, like Color 2 and other trials, they have shown that the laparoscopic surgery is equivalent. But some recent trials have also shown the contrary. So it depends on the skill of the surgeon is very important. Some people say that hospital stay may be reduced by a day, but ultimately you are increasing the blood loss, and maybe operating time might even double. So it depends on the skill of the surgeon. That is very important. And at present, it cannot be like generalized that whether laparoscopic surgery is better, because it depends again on center to center. So ultimately, the oncological principles have to be maintained. That is more important.
Exactly.
We have to do a oncologically safe surgery.
Exactly.
So in this case, it's a midrectal tumor. We'll be probably doing a LAR with a good quality TME. Let us consider some what if scenarios, like if there was a low rectal extension, low rectal tumor with levator infiltration, like what would be the extent of your surgery, Dr. Ashish?
In case of low rectal tumors, bulky tumors, because in these cases the mesorectal fat is very thin.
We have already given neoadjuvant treatment. After that,
the first thing is, for these patients, we should also like for even after long course neoadjuvant chemo radiation, we should prefer giving total neoadjuvant treatment. It will be a good option. And besides that, because the mesorectal fat is thin in these areas, so probably we will like to get wider margins. So in these cases, we can consider ELAP, extralevator abdominoperineal excision, so that we can take wider margins for these cases.
Okay. And suppose even after chemo radiation, there has not been substantial downstaging and MRF is probably still involved. Like, would you deem the patient to be palliative or go for a extensive surgery?
These cases, actually, this is a difficult question because these are tricky cases to operate. And for them, you will need you will need more extensive resection. And probably you will need to take extra margins for these cases.
Yeah, probably literally we may need to include doctorate of fascia and all. We come back to our radiation oncology colleagues, like suppose there was a lateral pelvic node, or let's say even a right inguinal node, FNAC proven inguinal node, like how would it change the treatment plan? Dr. Rubusonko, please, what would you do? Madam, your voice is not very clear.
Voice is breaking.
Can we go back go to Dr. Jyotiman, please?
Yes. So about the right internal iliac node, actually right internal iliac node is within the CTV of our neoadjuvant chemoradiation radiotherapy portal. So as per our guidelines, like ASTRO guidelines, internal iliac node is within the CTV. So I think that is not going to change our treatment. But yes, obviously a right inguinal node positivity, obviously it's a systemic disease. But actually, there is no standard guideline for the patients with an inguinal node which is FNAC positive. Although it's a systemic disease, in this type of patients, still our treatment can be a radical one. So neoadjuvant chemoradiation followed by surgery, which include your inguinal lymph node dissection, probably the option for this patient. Still, we can go with the radical intent. Though it's a systemic disease, we should not label the patient as a palliative in this patient.
Yes, probably when there is low rectal extension, there is a chance that the
inguinal node may be positive.
Yeah.
Yes.
Doctor, after would you include a inguinal dissection for such cases if the node still remains after neoadjuvant treatment, total neoadjuvant?
Yeah, on palpation, if I feel on table that there is a palpable node, I will go for complete pelvic dissections of or both pelvic complete dissections. And though there is not much studies to show about a positivity or benefit of that, but then my practice I would do that, and I would, because for me R0, the thirst for R0 should be there, and then I do that. So regarding studies, I don't know how much is showing beneficial. So you tell me about that.
Dr. Ashish, like would you differ or would you do?
Say that first thing is that even after neoadjuvant treatment, for the patients who have got a right inguinal node or maybe internal iliac nodes, we can do dissection, but we should be selective. I mean, we should not do it for every case, because first thing is that the patient should be responding well to the neoadjuvant treatment. And it should have either a stable disease or probably a good response before going ahead with surgery, rather than a patient with a bulky nodal disease, which might not be responding to treatment. Second thing is that about the concern of that whether it is systemic disease or a regional disease. So many new literature is showing that the patients with the internal iliac nodal disease, they can probably have got the survivals which are equivalent to the loco-regional case rather than the distant metastasis. So that is the reason that many people now want to treat them with curative intents, with the patients who are having the internal iliac or inguinal lymph nodes, which were earlier considered metastatic. But still, we should be selective in considering surgery rather than for all cases.
So in this patient,
can I just ask one question?
No one, yeah.
So all those cases where your lesion is quite high up, say rectosigmoid junction, where your right inguinal node has come positive on FNAC, maybe 1 centimeter, 1.5 centimeter, whatever it is. So what will be our intent of treatment, whether we will consider it radical or whether we will consider it as palliative? I'm saying high rectosigmoid tumors, not in a lower third where it is approaching the anal canal or lower third of rectum. So what will be the take on that, whether the surgeon will upfront consider it as a radical intent or palliative intent, or for that matter for everyone?
That clinical scenario is the clinical scenario is not very common, but then probably if there is no other sites of metastasis, that means nothing in the lung, nothing in the abdomen, nothing in the higher retroperitoneal nodes with a single site of disease. Probably we can give the patient benefit of doubt if he is or she is fit enough, and then find our results, like instead of just following non-curative palliative treatment. That
Yeah,
is
yeah,
my
I
viewpoint.
agree with Gaurav. I agree with Gaurav because regarding this, whatever evidence present is very limited. Mainly the retrospective series, there are very less number of patients, like 50, 40. So in many of them, they have sort of very good 5-year survival rate in this group of patients where they have taken a curative intent. So rather giving the patient directly at a palliative case, so it should be totally clinician-based, personalized.
So that's what I can go ahead with a PET CT
I
to
agree
rule out
to
the
that.
other metastatic.
Gaurav?
Yes.
Gaurav?
Yes, after the any
So,
further
yeah,
viewpoint?
I would like to have like the Ashish told that we will look for the response of the nodes. In this in this neoadjuvant and SATRT has give good you will have good response, but regression is very less. So there is difference between the response and regression. Okay, so regression is less. So your judgment for taking up the surgery should not be about the response of the or regression of the the nodes. That is my suggestion, or that is what I practice, and I have seen in the literature also. So in this study there is different. There is the neoadjuvant big about CR complete CR. We got good pathological response, but regression is there is on the T2 lesion up to T2 lesion there is a good regression, but beyond T2 or T3, T3, T4, they have seen there is very less regression. There is the CRM is almost less than 1 or more than 1 millimeter. So there is not much more difference in the regression. So in that view, we should not reassess on the basis of the response to the disease, response to the treatment. So a low response with a high risk might also do good in these subsets.
Yes, sir, even also, sir, besides responsive disease, even stable disease also we should consider surgery.
Yeah, exactly.
True. Even though we have discussed TNT in detail in today's scheme of things, in this patient underwent neoadjuvant chemoradiation and then laparoscopic low entry section, staple colorectal anastomosis, and of course a diversion leukoblastoma was done. I regret that I have come to the pathologist quite late in this panel discussion. Like Dr. Konglas, sir, are you available online?
Yes, I'm available.
Oh, madam, I'm sorry. I'm so sorry.
Yeah. No problem.
Like how would you assess an LAR specimen post neoadjuvant treatment, and like what are the important components of a histopathology reporting in such a case?
Okay, good evening, everybody. The LAR specimen actually post-adjuvant therapy, we would do the same thing as we do for a fresh specimen also. So grossly, the first thing we do is grossly we examine the macroscopic examination. We look for mesorectal clearance. That is the quality of the surgery. And also we do the various measurements of the tumor size and all that. And we look for any gross tumor perforation. In a post-neoadjuvant, the difference is that we do not usually find lymph nodes. And the second thing is the tumor site is very important in the clinical information because sometimes we might not find a tumor. So that is also extremely important. And sometimes, in fact, we had to call the clinician to actually pinpoint to us which one would be the tumor bed, because that is the most important. The blocks which we take from the tumor bed, we have to take at least 5 blocks from the tumor bed. If that does not show any tumor, then we have to do the entire tumor bed. We have to gross the entire tumor bed, and also we have to take multiple levels of each block, and then only we can identify that this is a complete pathological response. And that is very important. So when we look at the sections which we take, we include the tumor, we include the margin, we include the lymph nodes if we find, but usually in neoadjuvant, lymph nodes are difficult to find. And then basically in the serosal fat, if there is serosal fat, we have to identify tumor deposits because they give a very good prognostic information. And also we do a regression grading, that is by a modified Ryan's scheme of approach. And we give a grade from 0 to 3. 0 meaning there are no viable tumor cells at all. 1 means when there are very single small clusters. 3 is when we can see that there is a tumor response, I mean regression response, but there are still big clusters of tumor cells. And 3 is when there is absolutely no response at all. The tumor is as it was with multiple lymph nodes. So that is what we do in post-neoadjuvant specimens.
Thank you so much. Suppose this is a what-if scenario, like a complete pathological response. I'd like to come to the surgeon's like, what would be your reaction? Would you be happy? Would you be apprehensive? Like, what would be your reaction? Dr.
I will
Ashish?
just congratulate the patient that you have got a pathological complete response, so you are going to have very good outcomes.
Okay, that is central.
And so that he does not fire me back. So before that, I will congratulate the patient. And
very diplomatic.
And as per the literature is concerned, for such patients, slowly we are starting in the place where people are trying to do wait and watch policy for some of these cases. There may be after neoadjuvant treatment, some cases we can keep under follow-up, and in case some of them we can get away with surgery. So I really wish the same larynxing does not happen with the surgeons here in the rectum.
Yeah. Complete. I have a point, Gaurav.
Yes.
But complete response does not translate into, like, it is not a surrogate marker for a overall survival, good survival.
Yes.
It's not. It cannot. It is pretty early to say that. So that's I want to make this point.
Yeah, the point is very valid. It has not been proven conclusively that complete pathological response is equivalent to improved OS. To the radiation oncologist, let us give him the final word, because we keep on doing extensive surgeries, but then we always wish that the patient has optimal function. So we don't want to keep the patient on stomas and all. Would prefer that the patient has a good function. So let's the radiation oncologists have the final word. Like, what are your thoughts about organ preservation, like Dr. Jyotima?
Yeah, so there is no doubt that this total neoadjuvant treatment is now superior to the conventional chemoradiation followed by surgery followed by adjuvant chemotherapy. The benefit is not only in terms of oncological outcome, but also for patient compliance. So based on this evidence, it was postulated that a particular group of patients who have a complete clinical response could be kept under wait and watch approach. So based on this postulation, some trials came up. So you rightly showed the OPERA trial. Actually, this is a phase 2 trial, so it's not a strong evidence to say that wait and watch is a standard now. So as per the OPERA trial, at least more than 50% of patients had a 3 year survival, 3 year disease-free survival, if I remember. But we have to wait for some larger trials like a few trials are going on, like a prospect trial where they have used selective radiation, or they have omitted surgery in trigger trial based on some MRI response criteria. So these are large trials going on wait and watch policy. We have to wait for the results. Till now, wait and watch is not established. So TNT would be the TNT, means total neoadjuvant treatment followed by surgery, which would be the best option for this our patient.
Dr. Gaurav, am I audible?
Yes, sir. I can see the Dr. Kunjari Media joined.
Yeah. Just I wanted to highlight in rectal cancer, especially the locally advanced rectal cancer, primary treatment is surgery, we all know.
Yes.
And role of radiation, neoadjuvant radiotherapy and chemotherapy is only to make it is possible for surgery, that is sphincter sparing surgery, and to help to prevent the recurrence, to decrease the chances of recurrence. But after the surgery, after we have achieved a pathological response, there is also role of adjuvant chemotherapy in order to reduce the chances of recurrence, because as it is T3 and 2 disease pre-op, so there is chances of recurrence. So adjuvant chemotherapy is very much needed here. At least 3 months of standard adjuvant chemotherapy should be the option in this case after the surgery.
Yes, very true, sir.
My
sir, there was a question to you a little while back, like a
Yeah.
sequence of total neoadjuvant therapy. Like how do you go about it? Induction, consolidation. How do you choose your agents?
In induction, if we need at all induction chemotherapy, we give FOLFOX chemotherapy, and with radiotherapy, if it is standard course, long course radiation, then he is a 49-year-old patient, so this is a relatively young patient, so we can give capox chemotherapy along with radiation. But if the age is advanced and general condition is not so good, then only capecitabine is given with chemotherapy, with radiotherapy. But most of the cases we are using capox as chemotherapy arm in neoadjuvant setting. And in adjuvant after the surgery, usually FOLFOX is the regimen of choice.
Okay, sir.
Kunjata, do you also use FOLFIRINOX? That
No,
for disease?
no, we are not using FOLFIRINOX in this setting.
Okay.
Because of toxicity.
Gaurav, we are already over the time.
Okay. That was,
just to remark that there is already a just recently published article regarding the wait and watch approach from PMH Mumbai. Around 36 patients, around 36 patients were studied who had a complete CR or near complete CR, and the DFS for 3 years was 92%. Organ preservation rate were 80%, and the overall survival was 96% at 3 years. So there is a chance that slowly the trials will come up and we will have the better evidence for wait and watch.
Yes,
sir. So we come to the end of this panel discussion. I would like to thank all my panelists for giving us time and answering the questions patiently. And thank you organizers once again for being so patient for this 45 minutes. Thank you so much.
Thank you.
Thank you.
Thank you so much.
Thank you, Gaurav, and thanks to all the panelists for giving us the opportunity to conduct the session.
Thank you, sir.
Thank you, Dr. Kunjari Medi, at the last moment.
Yeah, thank you.
Thank you, sir. So we'll move on to our next session. The next sessions are the two sponsored talks that will be supported by AstraZeneca Limited. And for that, I will like to invite the first talk is given by Dr. P.S. Roy. Dr. Partho Sarthi Roy is the professor in the Department of Medical Oncology at B. Burwa Cancer Institute, Guwahati. He has done his DM Medical Oncology from TMH Mumbai. He will be speaking on the optimal management of EGFR mutations in the non-small cell lung cancer patients. So over to you, Dr. Partho. I think Dr. Partho is already there. Partho?
Yeah. Good evening, Vikas, and good evening all. Yes, I'm pretty well here. Because
you want to share the slide or we'll share from our side? Yeah, okay, it's already there. Yeah. Partho, can you hear us? Partho, can you hear us?
Yeah.
Yeah, you can start the session. Yeah.
My slide is visible?
Yeah. You are already sharing from our side. Yeah.
Okay, that's great. Okay. So without wasting much time, and good evening, a very good evening to all of you present here. And thank you, Vikas, and thank you, team AONEI, for giving me this opportunity. So I have given the task to discuss on optimal management of EGFR mutated NSCLC patients. Next slide, please. As you all know that lung cancer remains one of the most dreaded cancer in the mankind, and it's incidence wise it is the commonest cancer in worldwide, both in men and female, and so is the cancer related mortality also, because of the lung cancer is much higher, giving rise to, next slide please, giving rise to around 11.6% of the all total cases of cancer diagnosis worldwide, and 18.4% of all the total cancer related mortality worldwide. Next slide, please. So before going to the proper discussion of today's topic, let me just brief on about your lung cancer. Lung cancer is broadly divided into two groups. That is, one is small cell cancer, one is small cell lung cancer, other is non-small cell lung cancer, in short NSCLC. NSCLC comprises the 80% of the cases, more than 80% of the cases. And traditional morphologically, NSCLC can be broadly divided into squamous cell carcinoma, adenocarcinoma, adenosquamous carcinoma, and large cell carcinoma. But for this today's discussion, we will stick to the adenocarcinoma, basically adenocarcinoma NSCLC. And beyond this traditional morphological classification, metastatic adenocarcinoma or metastatic NSCLC can again be classified based on molecular profiling, like EGFR mutated NSCLC, ROS mutated NSCLC, ALK positive NSCLC. So we will not discuss the rest of the part, only we will focus on the EGFR mutated NSCLC patients. So when you talk about this EGFR mutated NSCLC patients, as far as metastatic NSCLC is concerned, the standard of care as of today, it is EGFR targeted small molecular tyrosine kinase inhibitor. In short, it is known as EGFR TKI. Altogether, we have 3 generations of EGFR TKI, and altogether we have 5 agents. In the first generation, we have 2 agents. In the second generation, we have 2 agents. In the third generation, we have 1 agent. Now, when to use which agent as first line so as to give the optimal treatment to the patient? This is our topic today. So next slide, please. So with this much in background, I shall discuss something about the optimal management actually. As I have already highlighted, we have 5 molecules. First generation 2 molecules, second generation 3 molecules, third generation only 1 molecule. And how we can use these drugs in the first line? So we have 3 options altogether. First option is traditional use of first generation TKI upfront. Second option is that we use the second generation TKI first, followed by use of third generation TKI. The third generation go for the upfront use of osimertinib, that is upfront use of third generation TKI in the first line. So we will discuss one by one. Next slide, please. So first start with the third generation osimertinib in the first line. Next, please. As I have already highlighted, this use of EGFR TKI in the form of either first generation or second generation, whatever may be, these are the standard of care in patients with sensitizing EGFR mutation positive metastatic NSCLC. So far, NCCN guidelines is concerned, current latest NCCN guidelines is concerned, you can see on the right panel, all 5 drugs, that is osimertinib, elranatamab, afatinib, gefitinib, dacomitinib, all are recommended as category 1 recommendation as far as latest NCCN guideline. However, osimertinib has been given a preferred recommendation in the first line treatment. Next slide, please. So this all the 3 generations of drug, as I have highlighted first, as probably you are all aware that first generation we have 2 drugs, that is gefitinib and elranatamab. In the second generation we have afatinib and dacomitinib. In the third generation only 1 drug, that is osimertinib. All 3 generations of drugs, they differ something in chemical structure, then ability to cross blood-brain barrier, then reversibility, then inhibition criteria, all those things. So the first generation and second generation, they are chemically anilino-quinolone derivative. Whereas third generation TKI, this is monoaniline pyrimidine derivative. So chemical structural formula is a little bit different. And the first generation TKI, they are in addition to blocking wild type EGFR, they also blocks EGFR sensitizing mutations. Whereas second generation TKI, they have added advantage of blocking EGFR sensitizing mutation. In addition to that, they can also block some rarer variants of EGFR mutation, which is an advantageous point for the second generation TKI. Whereas the third generation TKI, they have ability to block EGFR sensitizing mutations. But most importantly, why the drug was developed is because it is to prevent or get over T790M specific resistant mutation. And as far as the blocking reversibility is concerned, first generation is basically reversible blocker. So once the drug is withdrawn, again there is a disease progression. Whereas the second and third generation, they are irreversible blocker. And as far as the blood-brain barrier, crossing blood-brain barrier capacity is concerned, this is again most important game changer as far as the treatment of EGFR TKI is concerned in the field of metastatic NSCLC. So first generation and second generation, they have very minimal ability to cross blood-brain barrier, whereas the third generation TKI, they have significant ability to cross blood-brain barrier. Next, please. So from the cartoon, it is very evident that osimertinib, a third generation irreversible CNS active EGFR TKI, developed specifically to block that EGFR T790M mutation resistance. In addition, they also block EGFR sensitivity mutation. From the cartoon, it is very evident. Go to the left panel, EGFR mutation, common EGFR mutation, that is exon 19 deletion and L858R mutation, they are blocked by this osimertinib. In the middle cartoon, they are blocking T790 mutation, EGFR T790 mutation. It is very tightly. Come to the right panel, you can see this wild type EGFR receptor. They are not binding, or rather the activity to this wild type EGFR mutation is very low. And this lower activity to wild type EGFR is actually a therapeutic advantage of osimertinib. Having been said that, you are all aware that this wild type EGFR is situated in generalized skin surface and also in the mucous membrane. And so blocking of those skin surface EGFR receptor, wild type EGFR receptor and mucous membrane leads to your diarrhea, excessive diarrhea, mucositis and skin rashes, which is very minimal with the osimertinib. This is because of this pathophysiology. And in addition, it has also capability to cross blood-brain barrier. Next slide, please. So the landmark trial from where osimertinib got the recommendation and also got the FDA approval to use as a new standard of care for this first-line therapy in this group of patients coming from a phase 3 randomized trial. Its name, in short, is known as FLORA. FLORA trial assesses the safety and efficacy of osimertinib against the standard of care. In the standard of care, that time only gefitinib and erlotinib was used as a first-line TKI, particularly in patients with NSCLC who had metastatic or locally advanced disease with EGFR mutation status. Next slide, please. So very briefly, I will show you about this study design of this FLORA. Total patient recruited more than 500. They were randomized in 1:1 fashion to either osimertinib or to EGFR TKI standard of care, either gefitinib or erlotinib. In the patients, those patients who are in the standard of care arm, the crossover was allowed once the patient has progressive disease. The primary endpoint of the trial was progression-free survival, and stratification was done as far as the race is concerned. So they have tried to see how this drug fares in Asian versus non-Asian, but also as far as the different mutations are concerned. Next, please. Coming to the osimertinib primary endpoint of the trial, which is PFS, osimertinib demonstrated a significant improvement in the PFS with median PFS of 18.9 months versus 10.2 months, with HR ratio of 0.46, which is quite evident that it is highly effective. So 0.46 means at least patient with osimertinib had at least 54% less chance to progress on disease in comparison to the comparator arm with a significant p-value. As you must be aware that PFS is a direct measure of the drug affinity, drug benefit. So if the drug is beneficial, then probably, then definitely your PFS is shown to have marginal improvement. And FLORA was powered to see that PFS benefit in this trial. Next, please. When we talk about the different subgroups as far as PFS is concerned, this forest plot curve is very evidently showing that all the subgroups favors osimertinib, whether it is a gender or you take race, whether it is Asian, non-Asian, history of smoking or there is no history of smoking, presence or absence of CNS metastasis, and EGFR mutation status. All the subgroup it has actually favored osimertinib. One more thing I would like to highlight that this trial recruited at least 19% of the patients who had baseline CNS metastasis, although they were stable. Next, please. So far as the secondary endpoint, that is overall survival, is concerned, the study met its secondary endpoint. Also, osimertinib provided the overall survival of 38.6 months, which is more than 3 years, and more and more number of patients are still living at 2 years. That is 74% that will living at 2 years, and 54% patients living at 3 years. So this is for the first time we are seeing in a metastatic setting a particular EGFI which has translated PFS, not only PFS, that translated into significant OS benefit. Next, please. So if you are using osimertinib, so more and more number of your patients are still receiving or still staying alive at 3 years. So you can see from the right blocks graph, at least 28% of the patients, they are still alive at 3 years, whereas only 9%, that is almost 3 times of the comparator, the patients are still alive at 3 years. Next, please. So as the time to first subsequent treatment. When you take the comparator arm, the time to go for the second therapy is around 13.7 months, whereas for the osimertinib, the time for second therapy is 25.5 months, which is doubled. Next, please. So as I have already highlighted that PFS is a direct measure of the drug benefit. So PFS from the all major landmark trials which has given the approval for these particular drugs like gefitinib, erlotinib, aflotinib, and so on. So the comparison arm, you can see from 9.5 months to 14.4 months was a range of PFS benefit from different first generation, second generation TKI, whereas the extreme right corner, that is osimertinib from the FLORA trial, which showed the 18.9, which is the maxima as of today, as far as PFS is concerned. Next, please. So this is already I have highlighted. There's showing that in all subgroup PFS is benefited, PFS benefit in favor of osimertinib, and that PFS benefit is also translated into the overall survival benefit. Although the patient are not getting the equal overall survival, but the magnitude differs, but overall survival benefit is also there. Next, please. Yes, I have already highlighted this part. Osimertinib PFS benefits clearly maintained consistently across all groups, and all OS subgroups showed a positive benefit in favor of osimertinib, although magnitude varies. Next, please. So I won't waste much time in discussing the first generation TKI base because I am discussing optimal treatment today. I just want to show you one slide regarding this first generation TKI. Next, please. Next, please. So this is actually a comparison curve, which table, which shows Indian data of first generation TKI. Amongst these, all 5 randomized trial, 2 was from the TMH. All were evidently showed that all have concluded the same thing, that median PFS with EGFR TKI in Indian patients was similar to that of reported in the global statistics, global standards, which was ranging from 9 months to 14 months. Next, please. Now coming to the other remaining option, that is we have options of second generation TKI to start with, then subsequently we go for the osimertinib. Next, please. So before going to the sequence of second generation TKI subsequently to the osimertinib, let's discuss something about the few trials which recommends, which approves this second generation TKI. As I have already highlighted, the second generation TKI, already 2 drugs are there. One is afatinib and other is decomitinib. So decomitinib came from the major randomized trial, that is Archer 1050 trial. So I am just trying to cross trial comparison between this Archer 1050 trial versus FLORA. One is to remember that I am not we don't have any head-to-head comparison between these 2 trials. So whatever I am doing is the cross trial comparison. So please take my comments very with the caution. So as far as the primary endpoints are concerned, both the trial had tried to see the progression-free survival. And in the Archer 1050 trial, the decomitinib was compared against gefitinib, whereas FLORA trial compared osimertinib against either gefitinib or erlotinib. Next, please. So nothing to discuss about the inclusion or exclusion criteria, except one point to highlight is that in Archer 1050 trial, no patient with brain metastasis were included. They were excluded. On the contrary, in the FLORA trial, the patient with CNS metastasis, which were stable patients, as much as I have already said that, or as much as 19% of the CNS metastatic patients were included in the FLORA trial. Next, please. So the primary endpoint of both the trial was PFS. Both the trial were positive in their part. So first left part, you can see decomitinib fares better in comparison to gefitinib. So it was a positive trial. On the right term also, it was positive as far as the osimertinib is concerned. But the point I want to show you is that by this red highlight. So you can see in the left panel, the curve starts separating after 6 months. The meaning is that you won't like to have that PFS benefit after 6 months. You have to wait for 6 months. On the other hand, in the flora, osimertinib curve started separating. That is, Kaplan-Meier curve already started separating immediately after the treatment is started. Next, please. Next, please. Next. Okay, so left curve is not coming, but I would like to show that show you that overall survival for the Archer 1050, but is nothing to show because it was insignificant. Actually, overall survival was not insignificant. It showed that 34.6 months for dacometinib, but the trial has some hierarchical statistical flaws. Having been said that, they tried to see the PFS first. If PFS comes to be positive, then they will go for ORR. If ORR comes to be positive, then only they go to OS. But ORR came out to be negative or not significant. That's why they did not analyze overall survival, and hence you cannot consider this overall survival of Archer 1050 to be a significant one. Coming to the right side, this is for the Flora trial. As I had already highlighted, that the overall survival was significant. Next, please. Next slide, please. Go to the previous, please. Okay. So when the Canadians people, they're trying to make the consensus, they have put in this into note that as because the hierarchical statistical design has not met, so overall survival of that particular Archer trial should not become into consideration. Next, please. So I made it clear that dacometinib can be compared against osimertinib. What are the differences? Differences means that in the dacometinib in Archer trial, the brain metastases are not included, so we don't know about the efficacy of the brain metastasis. In osimertinib, yes, there was CNS metastasis were included. Median PFS was 14.7 months versus 18.9 months. And most importantly, what I showed you that Kaplan-Meier curve started separating after 6 months in case of dacometinib, whereas the Kaplan-Meier curve separated immediately after starting osimertinib in the Flora trial. And as because of the hierarchical gatekeeping procedure, as far as PFS, ORR, and OS is concerned, OS data is not mature, or OS data cannot be commented from Archer trial. And dose reduction, and most important thing, you come to the lower part, dose reduction was seen in 66% for dacometinib in Archer trial versus dose reduction of only 3% with osimertinib. And serious adverse events were seen in around 27% with dacometinib versus only 4% with osimertinib. Next, please. So in the left side, it was Lux lung 7 panel. I don't know why this curve is not showing. I'm extremely sorry. But the left side, we had one more landmark trial result, that is Lux lung 7 trial, which was for afatinib. Afatinib unfortunately failed to show the improvement in the overall survival, whereas Archer 1050 also failed to show that overall survival as far as dacometinib is concerned. So both the when you talk about both the second generation TKI, both the trial has failed in their major landmark trial to have overall survival benefit. Next, please. So coming to the again PFS comparison amongst the cross trial comparison. So first one for Lux lung 7 for afatinib, PFS is benefited. The trial in its place is a positive trial, but the curve starts separated at 12 months, so you are going to get the benefit after 12 months. So as for dacometinib, you will get to get the benefit at 6 months. It is again a positive trial. Coming to the third positive trial, that is a Flora for the osimertinib, is again a positive trial, but the separation is at baseline or starting of the therapy, means when you get the PFS benefit, it is very early to be evident in osimertinib. Next, please. Next. So when you talk about the brain metastasis, osimertinib, as I have said that this osimertinib has got the ability to cross the blood-brain barrier, and hence it was recommended by the NCCN as ideal treatment option for both the patients who are at risk and also those patients who had already brain metastasis. Next, please. So C progression can occur because of the poor EGFR TK penetration. Because this, apart from EGFR, osimertinib, all other EGFR TK has very poor penetration into the CSF. I mean, that's why brain becomes such a sanctuary site. So you can see even after initial response to the first generation or second generation TKI, the patient will subsequently relapse in CNS, whereas the patient will have response to the other part of the body. Next, please. So preclinical study has already confirmed that osimertinib can achieve significant brain penetration compared to other EGFR TKI, and hence it is considered as the treatment of choice for those patients with CNS metastasis. Next slide, please. So the effect of EGFR TK in CNS metastasis, FLORA had confirmed both the systemic efficacy and the intracranial efficacy, and hence osimertinib is considered to be the only EGFR TKI to report intracranial efficacy. And in FLORA trial, the efficacy of osimertinib was similar in patients, both, I have already highlighted that, both the patients who had CNS metastasis and those patients who are at risk of developing CNS metastasis, they get benefit. And a fewer number of patients have developed or progressed CNS disease when the patient was on osimertinib. Next, please. So when we see the systemic efficacy as far as PFS is concerned, those patients who had CNS metastasis on the left side, you can see in the patients with CNS metastasis also, the osimertinib is providing your PFS of 15.5 months against 9.6 months of standard of care. On the coming to the right panel, those patients who does not have CNS metastasis, in that group of patients, osimertinib gives you PFS of 19.1 months. Next, please. So the full set of CNS analysis, you can see that osimertinib median CNS PFS is not yet reached, although the standard of care has 13.9 months, so it's giving the statistically significant. So CNS PFS was statistically significant with osimertinib versus comparator arm. Next, please. So as I have already highlighted, those patients who are on osimertinib, there is 19 altogether. 19 patients has progressed on CNS, whereas 43 patients has progressed on CNS. Those who are on standard of care therapy. Next, please. Next. So that is why NCCN has said that, and for those patients who had brain metastasis with EGFR mutation, so osimertinib should be the preferred treatment of choice. Next. Next, please. Coming to the tolerability profile. Next. So although all grade toxicities were comparable in both the arm, but coming to the grade 3 or more toxicity, which is at almost a double in EGFR TKI comparator arm against osimertinib, which is around 18% versus 29%. Next, please. So these are all grade toxicities for osimertinib versus EGFR TKI of standard of choice, where osimertinib exposure was for 20 months versus EGFR TKI of comparator arm was only 11 months. And although 60% was seen in all grade toxicity, but high grade toxicity, it is grade 3 or more toxicity was seen in only 1% of the patients. Next slide, please. And depending on the all adverse events, duration and severity, dose modification was more required for second generation TKI, and as is evident from the different trials. As you can see from the LUX-Lung 7 trial, the afatinib was need to be discontinued or need to be dose modified up to 42% versus comparator arm of 1.9%. Same as in the Archer 1050 trial, for decomitinib, dose reduction was required for 66% versus 8%. In the FLORA, only 4% patients need required dose reduction for osimertinib versus 5% for comparator arm. Next. This slide I have already discussed. In the FLORA, you can see all patients leading to dose reduction is only 2.9%. And any adverse events leading to death is only 2%. This is most important. Whereas for recomitinib, as much as 20% of the patients, as much as 9% of the patients were had death because of the adverse events to recomitinib, and so as to reduce the drug intensities in CD at least 66%. Next, please. So one slide about the recombinant in geriatric patients. It has been seen that the geriatric patient, particularly patients more than 65 years of age, had higher incidences of grade 3, grade 4 toxicities. They have more dose interruptions. They have more dose discontinuation, and meaning that recombinant is not a very safe drug in to use in elderly patients. Next, please. So why I am favoring more for osimertinib to be used as an optimal regimen when in the first line regimen? This is because, for the next slide, next please. This will be evident from this cartoon. You can see the top panel. When we are using osimertinib in the first line, on the first hand, you will go for the osimertinib. You will go for the PFS of 18.9 months. Whereas if you are going for standard of care treatment, either first generation or second generation TKI, so we will get an average of 10.2 months versus 15 months of PFS. And one has to understand that if we are using the standard of care in the first go, then at least only 1/3 of the patient will have to get a benefit of osimertinib, because only 1/3 of the patient is expected to have T790M mutations, whereas 1/3 more patient will either they will fail to have T790 mutation, or they will be having any unknown mutation. So this patient will not get any osimertinib benefit. On the other hand, the other 1/3 patient, they will not fit for any sort of therapy. Forget about osimertinib, they will not get any other form of therapy. So altogether, 2/3 of the patient, they will be excluded from getting any benefit of osimertinib. Only 1/3 of the patient they might benefit from the osimertinib. Next slide, please. So if you next slide, please. Next, please. Yeah. So if you start with 10 patients, altogether 3 patients will be remaining to who will be sought to be considered to be eligible for a second line osimertinib. So 7 out of 10 patients who start with first generation, second generation TKI will be able to receive osimertinib in the second line, because it is not possible to predict who will develop T790M mutation after the first line. Next, please. So when we talk about the sequencing of second generation followed by third generation, we have one trial, that is GeoTech study. But unfortunately, this is our retrospective study. They have tried to see the sequential use of afatinib followed by osimertinib in patients with EGFR mutation positive NSCLC. Next, please. Although this GeoTech study showed that median OS of 41.3 months, this GeoTech study has suggested that we can reserve osimertinib for the second line after failure of the TKI to show a better OS. But one has to understand that this GeoTech study is a retrospective study. One has to take this result in the pinch of salt. Next slide, please. So I have tried to highlight the disadvantages, rather pitfalls of this GeoTech study, as the most important thing is a retrospective one. And the one more thing you have to understand that this study has included majority of the patients with exon deletion 19 mutation, that is up to 73.5%. For your information, this exon deletion 19 patients, they are the most considered to be the most suitable or most good patients as far as the TKI response are concerned. So any TKI you give in this group of the patient, they will respond. So probably this is why this GeoTech study has showed a very good positive result after sequencing. So in FLORA trial, at least deletion 19 was not that much. And moreover, there was no head-on comparison to see that whether gefitinib or afatinib followed by osimertinib is a valid option. So it is basically not possible to predict which patient will benefit from this actual sequence of afatinib followed by osimertinib. Next, please. So when you talk about the sequencing of EGFR TKI, starting with prior generation of EGFR TKI, either first generation followed by third generation or second generation followed by third generation, especially when the patient develops EGFR T790M mutation for osimertinib, that is a viable option. Yes, it is an option, but to me, it is not an optimal clinical care, because we are not able to define who are the patients who will get benefit from this T790M mutation, because who can develop this mutation, we don't know at baseline, unless and until we do that. Second thing, not every patient will get enough benefit to additional treatment. Means, as I have showed in my cartoon, that 1/3 of the patient, they will not derive any treatment in the third line, in the second line. So another 30% of the patients will not get to know from the tissue diagnosis or liquid biopsy that what is the successful. So having been said that, in second line, second, third line, you will not get any tissue or liquid biopsy to give a conclusive diagnosis of T790M mutation. And lastly, and the most important thing, the osimertinib has showed that survival benefit. Why not survival benefit to the patient, that overall survival benefit, unlike other first generation, second generation TKI. Next slide, please. So I came to my concluding slide. To summarize, osimertinib has demonstrated a clinical and statistically significant improvement in PFS, subsequently to overall survival, which is the greatest thing in the history of all metastatic EGFR and targeted therapy. And median overall survival of greater than 3 years, as I have already showed you. FLORA is the first time to show that EGFR TKI has translated PFS into OS benefit. And if you are starting osimertinib, there is high chance that around 30% of your patient will still remain alive at 3 years. Patients subgroup, all the patient subgroups consistently showed positive benefit as far as PFS is concerned, also as OS is concerned. And as far as the safety profile is concerned, these are not much concerned, because they are having very mild side effects in the form of mucositis and skin rashes. Only less than 1% of the patient probably they will develop some grade 3 toxicities. So these are the data. I think these data should be sufficient to confirm osimertinib as the first line standard of care in metastatic EGFR mutated NSCLC is concerned. Next slide, please. With this much, I would like to stop it here. And I would like to thank you once all for your patience hearing. And I'll be happy to take any comments or any question if there.
Thank you very much, Partho. I think we are already a little bit over the time. So if any questions, they can put in the chat box and you can answer it directly there.
Okay.
Thank you, Partho, for giving the talk and sharing for this opportunity. Our next talk will be given by Dr. Umesh Das. Dr. Umesh Das is a consultant DM medical oncologist. He is currently working at Nemcare Hospital, Guwahati. Dr. Umesh Das will be speaking on bringing the precision to medicine in newly diagnosed ovarian cancer, that is PAOLO-1 and SOLO-1 HRD trials. Over to Dr. Umesh. Dr. Umesh, can you hear me?
Yes.
Yeah, so you can start, Umesh. No problem. Thank you.
Is my slide visible?
Yeah, we are sharing from our side. You can just ask.
No, I am also sharing actually.
It is already on the screen. You continue.
Yeah. Okay. Yeah, good evening to all. Thank you, organizer, for giving me the opportunity for today's evening talk. This is the last talk for today's session. Today's talk is bringing the precision to the medicine to newly diagnosed ovarian cancer, that is HRD, that is the homologous recombination deficit. It is a new BRCA. So briefly about the epidemiology of the ovarian cancer. As we know, now almost 300,000 women diagnosed with ovarian cancer as per 2018 Globocon. Out of this ovarian cancer, 60% of this patient is in advanced stage of ovarian cancer. And if we see the treatment result of this ovarian cancer, 70% of the women relapse within 3 years after first line of treatment. So only 30% relapse, 30% remains relapse free. Out of this, 70% patient relapse within 3 years. If we see the 5-year survival rate, only 30 to 50% of the 50% 5-year survival rate. So there is a significant need for better first line treatment to improve outcome in a patient with ovarian cancer. As we know, ovarian cancer is characterized by multiple relapse, mainly in the advanced ovarian cancer. This diagram showing the relapse-free, progression-free interval. If there is a relapse, if number of relapses increase, the progression-free interval is decreased. So if in the first progression-free survival after first-line chemotherapy plus minus bevacizumab maintenance and after the debulking surgery, progression-free survival median is 12 to 24 months. This progression-free survival mainly depends on the outcome of the first surgery. And after that, if patient is relapse, mainly as I have already told, 70% patient is relapse in advanced cancer, advanced ovarian cancer. In second relapse, the second PFS is median is 8 to 20 months. If patient relapse, again in the third is only 4 months. Ultimately, this progression-free survival decreasing, ultimately patients succumb with the disease. So once the disease relapse, it is largely incurable in ovarian cancer. This is the progression of first-line management in ovarian cancer. Since 2003, the first line and the standard management of ovarian cancer is in the introduction of platinum and taxane-based chemotherapy, but there is no further improvement of survival with chemotherapy alone since the introduction of this standard chemotherapy. In 2011, there is a paradigm shift where introduction of bevacizumab that improves the PFS in ovarian cancer patient. In 2018, there is introduction of olaparib, that is PARP inhibitor, that in BRCA positive, BRCA mutated ovarian cancer patient, that improves the PFS benefit. And 2019, again, they have added olaparib plus bevacizumab as result showing olaparib also has maintenance, also has improved PFS, and bevacizumab also has improved the PFS. If we combine both olaparib plus bevacizumab in PAOLA-1 study, there is a increased PFS benefit in advanced ovarian cancer. This is the simple basics of the genetics. As we know, there is different insult. It may be internal or external. There may be radiation, chemotherapy, reactive oxygen species, replication error, and spontaneous mutation, which leads to DNA damage. When there is a DNA damage, there is a different repair pathway to activate for this DNA damage. There may be single base, single standard DNA breakage repair. There may be double standard DNA damage repair. So ultimately leads to, there is a end result of this DNA damage repair leads to some minor DNA repairment. There may be major DNA repairment. There may be the temporary cell cycle arrest. There may be permanent cell cycle arrest, and there may be transcriptional regulation, senescence, and apoptosis, and which leads to prevention of carcinogenesis. If this DNA repairment mechanism has defect, leads to genetic instability, which leads to carcinogenesis. As we know that homologous recombination deficit is present approximately 50% of the high-grade epithelial ovarian cancer. This diagram showing the different percentage of homologous HRD, which leads to genetic instability. This may be the BRCA mutation, this may be other HRR gene mutation, this may be the altered HRR gene expression, and other unidentified causes which leads to genetic instability. As because in the actionable mutation in the ovarian cancer is very less, so we have to target this genetic instability to improve the progression-free survival in advanced ovarian cancer. As I have already told, there are two main mechanisms for DNA repair. One is homologous recombination, another one is base excision repair. If there is this both mechanism has defect, there may be cell death. So this is the main theory behind the use of PARP inhibitor. If, as I have already told, for base excision repair, PARP enzyme is very much required. If we inhibit PARP enzyme by PARP inhibitor, if patient has the homologous recombination deficit, there may be ultimately lead to cell death. So homologous recombination proficiency is important in normal cell function. This is proficiency of homologous. This is for the normal cell function, and homologous recombination deficit is identified in critical and identified in patient with PARP therapy. So how do we identify HRD? First, we have to see for causes of HRD, as I have already told, different gene analysis, that BRCA gene or HRR gene mutation testing is to identify HRD. Then next one is for effect of HRD. The effect of HRD will be genetic instability, which we can detect it by genetic testing, such as loss of heterogeneity, telomeric allelic imbalance, and large-scale state transition. By these two techniques, we can identify HRD. Depending on the various test method, the detection of HRD also different. If we test only blood for germline mutation of BRCA, only 50% of the patient is positive for blood in advanced ovarian cancer. If we test tumor tissue, there is about 20% chances of getting the BRCA positivity. If we test for HRR mutation, homologous recombination repair mutation, that is around 31% of the patient of advanced ovarian cancer has this mutation positive. If we test for HRD, that is homologous recombination deficit, around 50% of the patient is positive in advanced ovarian cancer for homologous HRD deficit. So if we target this 50% of the patient, there will be PFS benefit. As per ESMO guideline, the ESMO guideline recommendation for HRD testing is the test level is #1 evidence for germline genetic mutation, then tumor BRCA mutation also the #1 evidence, and other are the GIS and loss of heterozygosity. This is the #2 evidence. This HRD testing in the newly diagnosed ovarian cancer setting to establish the magnitude of benefit conferred by a PARP inhibitor used in BRCA wild type high-grade serous ovarian cancer to identify the subgroup of BRCA wild type and who are more likely to benefit from PARP inhibitor. To analyze analysis is performed from DNA isolation from paraffin, formalin fixed paraffin embedded tissue to assess the two factors for detecting HRD. One is for tumor BRCA mutation, and another for genetic instability by myriad genetic instability scoring. If the score is more than 42, then genetic instability is present or HRD is present. For considering integration of first-line PARP inhibitor in clinical practice, first of all, in step 1, we have to see whether BRCA mutation is positive or BRCA wild type. Then, then we have to see HRD present or absent. Then we have to see in the second step, we have to see bevacizumab is indicated or not. If there are any contraindication for bevacizumab, what are the contraindications? In third step, the clinical stage, the neoadjuvant chemo versus primary surgery, the residual tumor, the platinum sensitivity beyond the HRD status, and expected toxicities. Now, the PARP inhibitor olaparib maintenance treatment in newly diagnosed ovarian cancer. This is the two main studies, phase 3 studies, SOLO-1 study and PAOLA-1 study. In SOLO-1 study, they have included newly diagnosed advanced ovarian cancer. Then for those having the BRCA mutation positive patient, they have surgery, maybe primary surgery or interval cytoreduction. Chemotherapy is used, standard platinum taxane based chemotherapy. After that, olaparib maintenance for BRCA mutated patient. This is for the solo one trial. For Paula 1 study, they have included both BRCA advanced, newly diagnosed advanced ovarian cancer, having the BRCA mutation positive or HRD positive and HRD negative. All patients they have included in Paula 1 study. Here also surgery, it may be in primary or interval debulking. Chemotherapy, standard chemotherapy, and bevacizumab was there in Paula 1 study, and then the olaparib maintenance. Now the solo 1 study. These are the inclusion criteria: newly diagnosed stage 3 and stage 4 high-grade serous endometrial ovarian cancer and primary peritoneal and fallopian tube cancer. Patients should have germline or somatic BRCA mutation. EGFR is performance status 0 to 1. As I have already told, cytoreduction surgery is the inclusion criteria. Another one is complete response or partial response to platinum-based chemotherapy. It is also another inclusion criteria. They have divided in one arm is olaparib arm, 300 milligram BID, and another arm is placebo. Another arm is placebo, 2 years treatment if there is no evidence of disease. The study treatment continue until the disease progression, or if patient with no evidence of disease, then stop after 2 years of treatment. Patient with partial response at 2 years could be continue this treatment. These are the endpoints. Primary endpoint was PFS. Secondary endpoint was PFS by a blind independent reviewer. PFS2 overall survival, and time for randomization to the second subsequent therapy, and quality of life. This is the result of solo 1 trial. If we see the curve showing widely separated both the olaparib arm versus placebo arm, the median PFS was 56 months for olaparib arm versus 13.8 months for placebo arm. If we see at 2 years, the PFS is 48% for olaparib and 21% for placebo arm. The median PFS difference for olaparib versus placebo is 42.2 months. There is a vast difference between placebo versus olaparib. If we see the PFS2 for olaparib is not reached versus 42 months for placebo, and time for the subsequent second line treatment is 41% for the placebo versus not reached for olaparib arm. OS data was immeasured. So this showing that olaparib reduces the risk of progression or death by 67% in advanced ovarian cancer if we treat with olaparib in maintenance therapy. If we see the common adverse event of olaparib, mainly gastrointestinal, followed by fatigue and anemia. These are the adverse events for the olaparib: nausea, fatigue, vomiting, anemia, diarrhea, constipation, mainly GI, and anemia and leukopenia. If we see the most of patients on the starting dose, remains on the starting dose. Starting dose, as I have already told, 300 milligram per day. Most of the patient was on the starting dose. The incidence for one of the side effects is MDS or AML of olaparib. The incidence of MDS AML remains unchanged at 1% after 5 years of follow-up. So incidence for AML also not increase in olaparib arm. This is another study for olaparib is Paula 1 trial. In This is the inclusion criteria: stage 3, stage 4 high-grade ovarian cancer, serous endometrioid or non-mucinous BRCA mutated patient. Surgery may be upfront or interval, as I have already told. Another most important criteria, inclusion criteria, was at least 3 cycles of bevacizumab must take patient before randomization. The randomizing patient should have no evidence of disease or CR or PR. They have divided olaparib same dose like 300 milligram BD for 2 years plus bevacizumab. Another arm is placebo plus bevacizumab maintenance for 2 years. Primary endpoint was also here same as PFS. My investigator and blind independent reviewer, secondary endpoint was TFST, PFS2, TSS, OS, safety, and quality of life. The main characteristic of this PAOLA-1 study patient is representative of the first-line population with unselected biomarker status, surgical outcome, and platinum response. There are pre-planned biomarker assessment was done. This pre-planned biomarker was tumor BRCA mutation, HRD, HRR status. And this is only the phase 3 trial with PARP inhibitor with active standard of care comparator. That is, standard of care is bevacizumab comparator. This is the only trial. If we see the result of this trial, PAOLA-1 trial, this is for the PFS of intent to treat population. The median PFS was 22.1 months for bevacizumab plus olaparib versus 16.6 months for placebo plus bevacizumab arm with hazard ratio 0.059. If we see the subgroup analysis, all the subgroup favoring olaparib plus bevacizumab arm. As I have already told, approximately 50% of the patient PAOLA-1 study has HRD positive. This HRD around 50% patient has the HRD positive. Out of this, BRCA tumor mutation was 29%, and other genetic instability positive patient was around 19% and 19%. If we see the result of this PAOLA-1 study, if we see the PFS difference between olaparib plus bevacizumab versus bevacizumab in intent to treat population, 5.5 months. If we see the tumor BRCA mutation positive patient, the PFS difference is 15.5 months. If we include only HRD positive patient, this PFS is highest, difference is highest, 19.5 months. And those having the HRD negative or unknown patient, PFS difference is only 0.9 months. For those having the HRD positive, including BRCA mutation positive, those having the HRD positive, including BRCA mutation positive, the median PFS is 37.2 months versus 17.7 months. Here, this is the population. This is for 48% of the patient HRD positive. The median PFS is 37.2 versus 17.7 months. At 2 years, this median PFS for olaparib plus bevacizumab was 66% versus 29%. And this is the PFS for median PFS for those having the BRCA negative but HRD positive. The median PFS is 28.1 months versus 16.6 months. This is 19% of the patient population, those having the HRD positive but tumor BRCA was negative. At 2 years, 52% PFS and 26% for the placebo. This is the population for the this olaparib plus bevacizumab significantly reduces the risk of second progression in intent to treat population also. This is second PFS, that means that also reduces the second progression. As this 36.5 months for olaparib plus bevacizumab versus 32.6 months for only bevacizumab arm. And this is for the PFS to benefit regardless seen in HRD positive patient with regardless of the BRCA mutation status. This is for HRD positive patient, including BRCA tumor mutation positive patient. The second progression is better with olaparib arm. This is for HRD positive, excluding BRCA tumor negative, excluding tumor BRCA, also showing the favoring olaparib plus bevacizumab. And this is for the HRD negative or unknown patient. As PFS is more or less same with placebo arm. This is regarding the stage high risk patient and low risk patient. Both PFS1 and PFS1, PFS2 favoring olaparib plus bevacizumab arm. This is for both stage 3 and stage 4 patient. PFS benefit is seen with olaparib plus bevacizumab. The median time to second treatment was olaparib plus bevacizumab 38.2 months versus 31.5 months for the placebo arm. If we see the overall response, those having the BRCA mutation, overall response was 64%. Those for the olaparib plus bevacizumab, those HRD positive and BRCA mutation also included, overall response was 53% versus 31%. Those are only HR positive, but BRCA was negative. Overall response was 32% versus 21%. Those HRD negative patient response is 13% versus 51% for the placebo. So in this slide showing that those having the BRCA mutation positive has the highest response rate, those including HRD and BRCA also showing the second highest, it is 53% of the response rate. If we see the adverse event, the grade 4 adverse events found in olaparib plus bevacizumab was 57%, and for placebo was 51%, almost same. These are the adverse event, mainly the hypertension, anemia, and leukopenia. These are the most common adverse event in the olaparib plus bevacizumab arm. Regarding the AML and MDS, incidence not increase even after follow-up of 5 years. Quality of life also not statistically significant between the two arms. The take-home message, the HRD test is the new BRCA test. It is a key biomarker for predicting PARP inhibitor response in first-line maintenance therapy in advanced ovarian cancer. What we have found in SOLO-1 trial, the maintenance olaparib shows 67% reduction in the risks in disease progression or death. Median PFS was 56 months on olaparib arm versus 13.8 months for placebo. PFS at 5 years, 48% versus 21% for the placebo. What we have found in PAOLA-1 trial, HRD positive patients show significantly improved PFS with olaparib plus bevacizumab versus placebo plus bevacizumab with hazard ratio 0.33, median PFS 37.2 months versus 17.7 months, demonstrating the importance of HRD testing in clinical decision making. There is a significant improvement in PFS1 and PFS2 with olaparib plus bevacizumab seen irrespective of BRCA mutation, the clinical risks and disease stage in HRD positive patient. But HRR and HRD is not interchangeable and should not be considered as a substitute for each other in the clinical practice in first-line management of ovarian cancer. Thank you. Thank you for patient hearing.
Thank you, Dr. Umesh, for the nice presentation. Any questions from the delegates? I hope there are no other questions. So I thank both the speakers for this sponsored talk from AstraZeneca, Dr. Partho and Dr. Umesh. And I also thank Bahar and Sayantan from AstraZeneca for supporting this session. Thank you. So we had come to the end of today's session.